Yes. So, well, I think all of them have seen me before. So I'm Maria Luisa Escobar, and I have a great team of people that decided to say yes to an idea of why don't we do a session like this. So how this came about, and why do we think that this is important? So we have been working on two initiatives, looking at a way to really implement, operationalize on the ground a rights-based approach to priority setting. So what do we do? How do we understand who gets what and why? So that in pharmaceuticals specifically, we are going to be discussing that topic in here. So we're going to have two sessions. We're going to have one session that will talk about how to do priorities, how they have done it in Australia with a multi-stakeholder approach, and also what does that have to do with a rights-based approach. So if priorities are set in a participatory way, in a transparent way, empowering citizens to be able to come and express what they need, we will say, okay, that is a rights-based approach. And if they are evidence-based, sound evidence-based, hi, thanks. So we just started. So we will say, we are talking about what we are going to be doing here, so for your benefit. So we are going to be talking about how to operationalize a rights-based approach on the ground to set up priorities, how to decide who gets what and why, and how to make those choices legitimate, or for people to really be able to apply them and being able to enforce them and everybody to accept them. So this relates to two initiatives that we have been working on. One has started in Latin America and seems to be now going to other countries of the world. And the other one has been in 3 countries in Africa, looking at how multi-stakeholders can improve access to pharmaceuticals through improving procurement and supply chain. So it was not enough to do, it's not enough to do very good priorities and set up a very good list, but how do we make it better so people on the ground really get the pharmaceuticals? So these are the two pieces of the morning. And I would like to say that I was going to say, come here and sit here, but it's quite uncomfortable because you cannot see if you sit here. So I will pass Leonardo Cubillus, who will chair the first discussion with our guests. So Leonardo, please. And thanks very much.
Thank you, Maria Luisa. I'm standing here in front of the microphone. I'm sorry for standing behind the podium, just because we are being webcasted in www.saludderecho.net and www.ineb.net. So we want also then to hear what's going on here. So thank you so much for this introduction, and I'm pleased to introduce 3 of our colleagues and partners that are sharing with us their experience and their lessons, and sharing with our other client country partners. They have participated in several of the activities, and they've also written a number of papers that have conceptually guided our work in the initiative around the use of a rights-based approach to deal with priorities. We have 3 distinguished guests today. Dr. Jaime Caro. Dr. Jaime Caro is a physician. He's an internist. He's a Canadian citizen and a professor of biostatistics and epidemiology at the University of McGill. He's also Senior Vice President of United Biosource Corporation, and he will be sharing with us an overview of the different perspectives, technical perspectives and procedural perspectives of setting priorities that are currently being used in the world. Professor Siri Gloppen, please come join us. She Siri is a professor in political science at the University of Bergen, and she's the research director at the CHR Mikkelsen Institute in Norway. As I have shared with Citi, but I also want to share it publicly. One of your papers was foundational in the work that we are doing in not only Latin America but elsewhere. You published it in the Harvard Journal of Human Rights, HRH, and it was about litigation to hold governments accountable. And in that paper, you explain kind of the pros and the cons of litigation and the rationale behind that. And that was kind of it was foundational in a sense that we found both political science arguments, but also public health arguments to understand what was going on. So we want to thank you upfront for this. And Professor Lloyd Sampson is an Australian citizen, and he is a pharmacist by training. He's a professor emeritus of the University of South Australia. And very importantly for this case in point, he chaired PBAC for 10 years. PBAC, Lloyd will share with us a little bit more of the importance of PBAC. But PBAC is one of the, I would say, successful models or very interesting models in A, selecting medicines, and B, making sure that the selected medicines actually reach the Australian population, and C, updating this essentials medicines list, which is by no means easy. In as much as Siri will share with us what is going on in terms of holding governments accountable for their decisions, Lloyd will share with us what he learned, or Australia learned, in setting these priorities, in implementing these priorities, and what could be exported in terms of these priorities to some countries of the world. So throughout these 90 minutes or 85 minutes that we have left, we will do three things. First of all, we will hear from each of them a 15-minute presentation. We will start with Jaime, then we will go with Lloyd, and then we will hear from Siri. And then we will engage ourselves in a debate. We will see if we have a debate amongst the panel here, or integrated. I probably believe that we will have an integrated debate, and we will also be receiving questions from the audience online, Salud Derecho and INEP. And then we will close at 10:45 just for the coffee break. So I want to thank you for being here, traveling from Canada and Boston, mostly from Norway and from Australia with an intermediate step in Barcelona. Lloyd, thank you. And I want to give the floor to Jaime, who is going to be our first presenter. Thank you, Jaime.
Do you want them to sit there or go back so they can see the presentation? Yeah. Do I need to pull it up, or will it, is it not mine? Is somebody putting the presentation up, or do I need to find it?
Yeah.
Sorry, no, this is not mine. I can try and give it, but I might say very bad things. While we get the presentation up, a brief introduction of what my background is so that you understand what I'm presenting. I've been working in the health technology assessment field since the 80s when Quebec first started doing this. I was the first head of methodology for the Quebec Council. Most recently have advised the German government on a method to do priority setting for their healthcare system, a method which was approved by the Bundestag and then rejected by the Minister of Health, which is one of the things that perhaps we'll get into the discussion about. In terms of how politics comes to play in these decision-making systems. So that's sort of the some of the background that I come from. And what I will try to cover, what I was asked to cover is an overview of the different approaches that countries have taken to this.
Can I have your key again? Oh, sorry about that.
So to not waste any time, I'll just keep going. The problem of prioritization comes, of course, when we implement any kind of universal health care coverage, because in doing so, we transfer the decision making from the patient and the doctor and what the patient can pay to a decision making body that has a social responsibility to make those decisions. And while that has many good features, one of the bad features is it removes the market from the decision making. There's no market that helps make a decision. So somebody now has to implement a set of values and arrive at reasonable pricing without having a market to help them set it. It turns out that that's one of the most difficult things that we have tried to do as humans, because like it or not, markets provide a mechanism for setting the prices. And when you take them out of the equation, you have a problem that, and I'll jump to my conclusion, that we haven't really been able to solve. I think what we'll try today is give you some of the approaches and some of the pros and cons to those approaches, but without I think, resolving it one way or the other.
You know how to bring your receiver?
Yeah, please. Where's the...
Yeah, I can't find it there.
F5 should do it. Okay.
Thank you.
All right. So a very simple problem to focus our thinking about this. Let's suppose that we are thinking about obesity, which of course increases the risk of various morbidities, diabetes, myocardial infarction, and so on. Let's take a made-up pharmaceutical that appears on the market, Sothinmab. And Sothinmab turns out to produce very significant weight loss in its clinical trials. It turns out to have mild side effects, unlike many of the weight loss drugs that have appeared before. And the company that is going to market this wants to price it at $2,500 per year. So the question is, should our universal health insurance cover it? And how do we approach this problem? The approaches break down into the following categories. First, we have the clinical approach. The doctor says, hey, if it works, cover it. You need to cover it because it's been proven to work. The economist says, wait, not so fast. Do the benefits exceed the costs? If they do, then cover it. If they don't, I don't think we should cover it. Lately, the judicial powers have come in, and we could say that maybe they say, if I say so, cover it. But if we're nicer to the judicial system, we could say, if the doctor says so, then you should cover it. So here's the three sort of main approaches out there today. There is an alternative, which I have been thinking about and slowly developing, which if we have time during the discussion, we can perhaps get to, but it's not a main part of my presentation since, as best I know, nobody implements it today. So the approaches to coverage, the economist's approach has taken hold in many countries with variations. They don't all implement it the same way, but Australia, New Zealand, Canada, the Nordic countries, the UK, Portugal, Switzerland, and so on have implemented this approach over the past 25, 30 years. Other countries have largely focused on the clinical approach. France in particular, Germany, Austria, Italy, although Italy says it does the economist's approach, but in fact, if you look at the decisions, they're clinical decisions. And of course, for the most part, the U.S., although there is no single healthcare system in the U.S., so it's hard to speak about the country as a whole. But for the majority, it's more on the clinical side. Spain is a mixture because it's regional, so there you have both approaches in different regions. Other countries, especially in the Far East, are leaning in one way or another. Japan is leaning towards the clinical system. Korea has implemented a economist-based system. Taiwan has implemented an economist-based system, and so on. South Africa is more on the economist side, but it's not fully implemented. Latin America is in the balance right now, with different countries experimenting with different approaches to this. I don't think there's a firm decision. Most of Africa has not gone one way or the other, nor has the Middle East, except for Israel. You can see Russia is a large white empty space because no system has been implemented there either, or in China. So let's look briefly at the economist's approach. What does this mean if benefits exceed costs? Cover it. Economists have very precise meaning to those words. They're trying to answer the question, what is a reasonable price for this so-thin mab? Or another way of asking the same question, different countries ask it either way. At $2,500 per year, is it reasonable to pay for so-thin mab? That depends on whether you can negotiate the price or not, which way they ask the question. So the economist stands up, goes to the blackboard, and writes out what we need to worry about is the net benefit. I want to make sure that the benefits exceed the costs. And I can break out these benefits into health-type benefits and resource use type benefits, less hospitalizations or fewer procedures or something like that. And there are some costs. I'm going to give up some things in health if I implement this therapy, plus there might be some side effects. And I might give up might have to spend some resources in order to achieve these benefits. So if this nets out positive, then I'll be happy. And how do I net it out? I put monetary units to value all of this. So everything is valued in monetary units because money is our universal currency of value. The health economist comes along and says, okay, we're talking about the mid to late 70s now, when this first started to enter medicine, and looks at this equation and says, okay, it's interesting, but the only thing is I don't accept that health is valued in monetary terms. I don't accept it for a variety of reasons. If you go back to the early writings, it's very interesting to see some of the arguments, but essentially a rejection of valuing health in monetary terms. We can then reorganize the equation and say there are things that are about health and things that are about resource use. The resource use ones we accept the value in money, but not the health ones. Now we have a problem because I can't subtract this thing since I don't have the same units in the two major components. No problem, we'll create a ratio. The ratio then doesn't require that I have the same units. I'll put the numerator as the costs, the net costs, and I'll put the net health impact on the denominator. And now I have what we call the incremental cost effectiveness ratio, or ICER. So that's nice. We've solved our problem without putting monetary units to this. Different countries might approach this differently in terms of the health side early on, but today it's pretty commonly done that you value health in something called the quality adjusted life year, which is a way of putting together quality impacts and longevity impacts, life expectancy impacts into one measure. So here are a whole bunch of evaluations done by the agency in the UK. They're listed by number and ordered from the lowest cost effectiveness ratio to the highest one. And so you look at these and you ask the question, should universal health insurance cover these? Well, we don't have an answer because we just have this number, this ratio, so we don't have an answer. So what can we do? Well, we can put a line across this at, say, £30,000 per quality adjusted life year, and now we can divide these into things that I think I should cover and things that economically I don't think I should cover. And so that should answer or help us answer the question, but we start to experience some problems. What if this one that I'm pointing to is a very severe illness that has no other treatment other than the one proposed? And what if this one down here is wart removal? Cost effectiveness would say cover the wart removal, don't cover the severe illness with no treatment because it's not cost effective. That sort of decision making as it gets out into the public has led to the major medical journal in the UK, the Daily News, to publish repeatedly things such as this. And they're popular reactions to what is perceived as an unfair decision. Whether it's fair or unfair, we can debate in the discussion, but this is the kind of popular reaction that comes out because of a perception of unfairness in the decision. Along comes the judge and says, wait a minute, I agree with whoever's in front of me complaining that they're not being covered. I think if the doctor says it works, then you should cover it, and interferes in the process, countermanding the evaluation that has been done. So that's one way, and the judicial reaction to that. What about the clinical approach? The clinical approach says, forget about this cost-effectiveness ratio. It's too complicated. I don't get it. People don't buy it. I just forget about it. So get rid of that. And this cost business and all that, yeah, okay, we'll have to pay some attention to it, but let's put it aside for the moment. Let's focus on the health. Is there a positive health effect or not? And so I could say there's a very positive health effect, a somewhat positive health effect, no difference from the existing therapies, worse than the existing therapies, or hey, the studies are not conclusive and I don't really know. And based on some sort of rating like that, called the SMR and ASMR system in France, called the AMNOG-based system in Germany now, but they're all very similar in character. I rate the health benefit, and then I say, should universal health insurance cover it? Well, if it's highly positive, definitely let's cover it. If it's somewhat positive, let's cover it, but not at such a good price. If it's no better than the existing ones, we'll cover it, but we won't give it any more price than what existing treatments are, so I reference price it to something. If it's less good than the existing ones, well, definitely don't cover it, get rid of that. And if I don't have enough information, well, I'm not sure what to do. Maybe ask the company to get more information, maybe offer to cover it temporarily. That category, which happens to be a big category, has not been very well clarified by the various countries that implement this kind of system. To conclude then, a little taste of the idea that I've been pursuing. So we've looked at the economic system, the judicial interference, the clinical approach, which ignores the whole cost side. In the needs-based priority idea that I've been developing, we would focus on the need, the perceived need for an intervention, with the idea that most societies would agree that things that are produce an extremely high risk of death are very high need. So we want to cover the acute heart attacks, the trauma, severe infectious illness, and so on, because they threaten to cut life short. In the middle area, we look at things that produce major permanent dysfunction, severe illnesses that paralyze you, stroke and things like that, or major symptomatic conditions. We want to make sure that if there's severe symptoms, pain, and so on, that we do something about this. And in my view, if you started building from scratch a new country, a new healthcare system with limited resources, you probably stop somewhere along here. You can't afford, with that universal coverage, to go down to the next layer. But in wealthy countries where you have more resources, then you would move into covering lower priority, lower needs, like minor symptomatic conditions, risk factors that indicate future problems like high cholesterol or that sort of thing. And then at the very lowest things that are perceived as largely cosmetic. This is a very, very, very superficial categorization. To make this practical, of course, this needs to be developed and quantified, and I have been working on the algorithms for doing this. So the decision maker then, which is not necessarily a doctor, the doctor pops up there because I was addressing a group of doctors with this idea, is that the question you're asking is, can the need be met with what I have available? Affordability is always going to be a part of the decision making, and efficiency by itself cannot address the affordability. So in conclusion then, this is a very difficult topic. In 15 minutes, it's hard to make it obvious just how difficult it is, but it is a very difficult thing that we try to do. The focus on efficiency or cost effectiveness, as has been practiced by many of the health technology assessment agencies, gives us some problems. We have difficulties establishing the appropriate threshold. There have been recent attempts in the UK to do this empirically, but there are some very difficult problems to solve in trying to establish a threshold, even in trying to define what the threshold means. It's difficult with an efficiency-based system to fully reflect society's values. Over and over again in Norway, for example, Eric Nord has done a lot of work showing that the priorities of societies don't always accord with what a economic threshold would seem to indicate. And then there are these persistent perceptions of unfairness which open the door for the judicial system to act and so on. If you avoid the economic considerations and say, I'm going to get rid of that whole problem by doing this clinically oriented, you have other issues that come up. First of all, consistency amongst the decisions. Once you're doing it behind closed doors based on some assessment of the clinical basis, consistency becomes a problem. Closely related to that, and it's interesting that in France, the commission that makes the decisions is called the Transparency Commission, and they make the decisions behind closed doors. A Gallic anecdote. But transparency becomes a problem. When you're making these decisions without any clear rules as to how they're made, without any algorithm as to how they're made, transparency becomes a problem. And of course, then providing a rationale for your coverage decisions is a very weak position, since you don't have an algorithm that you can point to. Judicial intervention based solely on the clinical opinion, in my opinion, deepens the problems. It makes these problems even worse. Perhaps a system that begins to move towards needs-based prioritization could solve some of the problems. There are some developments in this regard in the Netherlands in particular, but it's an area that is still very much at the beginning. Thank you very much.
When I get back to the desktop, should have been able to go back to the desktop from there. Should have been able to get there from there.
Here.
No, there it is. I couldn't see it. Here we go again.
Do you want to minimize this? Yeah, hold on a second. Do you see there?
No, it's on desktop. Desktop is there.
Do you have your flash drive?
Demo file. Let's get a demo file. Double check.
From your,
Yeah, yeah, sure. Thank you very much, and good morning, everyone. And thank you for me the opportunity to come and interact with you today. Jaime mentioned some of the things that I wanted to talk about, and I suppose I should declare myself as a pragmatic economist approach, because I think the definitional issues are important. Jaime used the issue of a quality threshold. Well, I think what's got us into trouble in the economic area is the concept of a threshold rather than a cost per quality being a framework for decision making. And I'm sure we'll tease that as we go through. Let me go through these quite quickly. I want to make the point right from the front that one system is not going to fit all. And some countries, the economic approach is going to be more appropriate, and others, some other ad hoc approach. And the more I'm asked to talk about the Australian system overseas, the more I want to say to people, it works for us. It may not work for you. And I think that's an important context, that you can learn from other people, but don't copy their system, because their system has developed quite uniquely within their own context, politically, social, economic, and so Can I also say, I've just come back from Barcelona from a meeting of industry, a group of industry representatives and payer representatives from around the world about what is value. And I want to talk about that also because that is so complicated and so in the eye of the beholder that the value approach, although it seems logical from a consumer perspective and so on, it is extremely complicated. And I just want to raise those issues. So my first slide is simply that the economic climate which is pushing us internationally at the moment is horrendous. And every country in the world, not just the developing country, the developing world is in a mess in terms of the future costing of healthcare. Now, I've just come back from Europe, and I've spoken to the people from NICE, the National Institute of Clinical Excellence, which makes decisions, and then I went and spoke to the NHS people who has to pay for those decisions. And there are tensions at that interface. So the need to assess value for money has become increasingly common and increasingly important for decision makers. So I'm going to whiz through these quite quickly. Now, the context of making that value judgment tends to reside in the health technology assessment domain. And I think we need to define what we mean by health technology assessment, because again, it's a term which is thrown about. My definition involves the medical, which is the scientific clinical, social, ethical and economic implications of the development and diffusion of a health technology. So it's not just economics, it is social and it's ethical. So that's where the right to health or the right to access is not an enigma within HTA, but a part of it. And I think, unfortunately, some people have got this approach that an ISA is benefit, boom, bang. That's just, no, it's not. That's one component of it. You've then got to put it within a construct of value. The other thing I want to talk about in terms of access to a pharmaceutical or a health service is simply the start of the process to a health outcome. And in any system of access or subsidy, it's got to be within a broader overarching policy. So it's no point in saying about an equity framework without talking about a quality framework. It's also, you can't do it without acknowledging the whole impact of stakeholders and where they come from and what their expectations are, and then put it into a framework of quality. All right? I think we often ignore quality in the context of a health outcome. All right? In my country, we have 160,000 people admitted to hospital a year, which is drug-related, costs us millions and millions and millions of dollars, and 70% of those are preventable. So if you're going to come up to this, it's not just about the economics, it's about how you ensure the access of quality and the attainment of quality and value right throughout the process. If you take your eyes off the ball at the first hurdle, you will trip over and trip over badly. So in any one of these, what we're trying to do is to balance health needs on one hand and fiscal discipline on the other. There is that tension. If we lived in a utopian world, then a lot of this, if you want it, yeah, try it, see how it goes. If it costs us $1 million and it fails, doesn't matter. Well, in this case, the opportunity costs that we are seeing now in health are just eating us up. We have drugs worth $1 million per patient per year for some of these rare diseases, which might be life-threatening. But the issue is, the ultra-orphans, can we afford the ultra-orphans? Where does the right to health of an individual impact on the right of health of another individual? Because we spend all the money. Often clinicians will tell me, I'm only interested in the patient in front of me. And my response is, that's true and that's good, but decision makers are also concerned about the patients in your waiting room. If you spend it all on this patient, what are you going to offer the next patient? So there's this tension between health needs and responsible fiscal discipline. And if you want an example, look at the example of NICE and the NHS. All right? It's a real issue. Those supply and financing arrangements, I think, must have a focus on optimising health outcome and representing value for money. If we don't do that, then I think we have no framework. But on the other hand, the access to these services or medicines must occur at a cost the individual and the community as a whole can afford. There's those two dynamics that you've just got to bear in mind. So what I want to raise is this question of value. What is value? Value for money. Is value and value for money the same thing? I put that question to the audience last, whatever it was, Sunday night, and I got mixed reactions. So the major issue is the health gain. Everyone says that, well, if it doesn't have a health gain, therefore it is of no value. That's true, maybe. I want to challenge that construct also. But I put it to you, if a medicine has a similar clinical benefit, but additional benefits for the health system, then it may be seen to have added value, even though its clinical benefit is no better. And I want to raise the question here, and I want to try and stir the debate this morning. So if I've got a drug which is cheaper, but slightly less effective, does that represent value for my health system? Because I can treat more people. So it's just when I'm talking about pragmatic economics coming into it, that you balance those off. And these are some of the issues about value. As I said, when we look at value, the first thing in ISA, you look at a clinical trial and you look at the outcomes of that clinical trial. Well, most of the clinical trials today are non-comparative. If you can't look at value for money, then if you want to look at value for money, you've got to look at comparative health gains. And many of the trial data we've seen, on which we make clinical judgments, are in a confined clinical trial, which are not comparative, which invariably these days have uncertain clinical outcomes. They're surrogate outcomes. We don't know what that means for an individual value in terms of a health outcome. But everyone at this meeting last week agreed that the clinical value is an important component of the total value. And in fact, they suggested it was the majority of the benefit of value. And to some extent, as Jamie just said, the ISA is often easily quantifiable. You know, we put in economic models and black boxes in and black boxes out, and if we believe things well. But it's quantifiable, we get a number. But there's lots of other things of value which are less quantifiable. And Jamie raised the one of severity of condition treated. And so his hierarchy was we should focus on those where the disease actually, threatens life. So the severity of the condition is important, and that's where NICE got into trouble to some extent, with the end of life, with their front page of the Sunday Mail, whenever it was, about sunitinib, it was the renal cell carcinoma drug, because it didn't fit their 30,000 per quality. In Australia, we funded it at 65,000 per quality. All right. Why? Because of the severity of the condition, the presence of effective alternatives. In renal cell carcinoma, there was none. This was the first drug ever to show a clinical benefit. So you can see where you start. You start off the quality, and then you start asking questions. The ability to target those most likely to benefit. Because if I take Jamie's viewpoint about you look at those where death is imminent, diseases are not monolithic. They are distributional. So there are some of those people which are going to have a greater risk than others. So do you focus on them? Then what about the right to health of those that you're ignoring? If you're targeting a group which is at higher risk, what does that do to an equity framework? Uncertainty. As I said, you've got a surrogate outcome. And we see these repeatedly now. And many of the surrogate outcomes, who knows what they mean for patients? Who knows? All right? So why should I spend a lot of money and accept the price that the company wants where I'm uncertain of the benefit? And the greater uncertainty I have, the greater I have uncertainty about what price they want to charge me. Social values, patient preferences. We don't ask generally what patients want. The only country I know that does that to some extent is the UK through their citizens' juries approach. Wider societal benefits, productivity gains. The industry wants us to take productivity gains into account. But of course, in many cases, in many countries, a non-realisable cost. You don't get it back. Someone else provides the productivity. And what do productivity gains do in an equity framework? Because children don't work, the elderly don't work. See, you start to, all these terms that just roll off. When you talk about pragmatic economics, you can see that it is an extremely, as Jamie said, this is a complex problem. And I don't think there is one answer. That's, I think that's the framework, the question of equity that I raise. The impact on carers, the entire health system regarding patient management. Right? I mean, if you do something and there's cost offsets that are legitimate, but there's some other cost offsets, or not there are some health benefit offsets, systems benefits we don't catch in monetary terms. Easier administration, more stable preparation. It's not as good as, well, it might be no better than, but I'll pay you a bit more because of things like being more stable. I don't have to, especially in the developing world, in my country, which is a big country, where you've got distribution issues and so on, then having a preparation which is more stable is something I would value and I would be prepared to pay for. Quite unrelated to clinical benefit. Innovation. Companies want us to pay for innovation. I have great issues with what the term innovation means. As a purchaser, purchase of a health, innovation to me is a health gain. If it doesn't have a health gain, it's not innovative. But people will argue, the industry people will argue, that's not true. And if you want to see progress, then you've got to reward innovation. We have no mechanism of rewarding innovation at this point in time other than through a health gain. Development of resistance, we might limit the access of a drug because we're concerned about antibiotic resistance, for example, government health priorities, and the issue that I think that Jamie raised, which is often one we don't tend to think of, that what way we lose if a new technology has significant impact and no new money flows from that. And we're not seeing any new money flowing in too many countries at the moment. For example, we've just been looking at the new oral anticoagulants in Australia, which is most countries are looking at, to replace warfarin. It'll cost the Australian government $1 billion over the forward estimates of 4 years. I can tell you the only way that will be funded is if $1 billion comes out of the health system somewhere. And then you've got to decide, well, where does that come from? And many health ministers will say, oh, the system is inefficient. You can find efficiencies. Well, I asked that question to Sir Andrew Dillon the other day, who's the chairman of NICE, the CEO of NICE. He said, the way we've been doing it is to limit the salaries of public service workers. In other words, putting a freeze on salary increases of health professionals and health service providers, because that's how we've been providing it. But is that sustainable? Because what's the negative impact of people's economic status going down? All right? And then do they get into health issues because we've pushed down their socioeconomic status? I mean, it is extraordinarily complicated. This is this incremental cost effectiveness that we talked about, and I just want to point out that these are the quadrants we call about the quadrants. In this quadrant here, the new intervention is superior, but it has a cost, an incremental cost. So the question is, how much are we prepared to pay? Where does this line, which is above or below? But of course in here, the intervention is less effective and more costly. Well, none of us, I don't think, want to pay for something which is less effective and more costly. So that's a no-brainer. This one here, the intervention is more effective and less costly. Well, we all want that. But down here, the intervention is less effective, but it's also cheaper. Does that represent value? Or do we immediately delete that? Or do we try and put it in a different value construct? And I have no answer to that. Well, I can give you an example. We have done this in Australia, where there are examples where we have done this. The reason is we can treat more people with the money that we have available. So the Australian health system that people want to talk to me about is quite unique in Australia. We have universal access. So the right to health is there through and it's been there since 1918 was the first when it started. And there's committees and structures such as the PBAC, which is an independent expert committee. And one of the interesting things we talked about where the judiciary, the Minister of Health or the government, cannot list a drug on the pharmaceutical benefits unless the committee says yes. So that's where the political process came into being. A no means no. The question is, does a yes mean yes? And I can assure we have a government in Australia at the moment who's saying, I can't afford to, but we have an opposition who's saying, yes, they will afford it. So all of a sudden this question has become politicised, even though the committee's decision, are non-political. Let me go right through to the end of this, and I kept these slides in just for if we need them later on. But the fundamentals. What do I think about the fundamentals in the Australian system, and why we believe it works, and what we need around it? First is the independence of decision makers and the lack of political interference in that decision making. The access issue is political. I mean, there's only 3 committees in Australia that bind government. The first is the Electoral Commission, so they can change the boundaries and government can't interfere. One is the Reserve Bank, who sets interest rates. The third one is the Civil Aviation Authority, so they want to, ground all the planes, they can do that, and the government can't do anything about it. They're the only 3. All the rest of the committees in the Australian system are advisory to government. So in the PBAC, the issue is that, Minister, we believe this represents value for money. In the majority of situations, the governments have said yes. In the last 18 months or so, governments have deferred that implementation because of financial issues. The subsidies in the context of an active medicines policy, and I can't stress that enough. It's got to be part of a national framework of medicines policy. You need an effective drug distribution system with formal government agreements about markups and fees and medication management services. You talk about, you can't, you can make the thing available, but if you haven't got a distribution system which is effective and manageable and accountable, then the system will collapse because you won't get those health outcomes. The requirements by wholesalers, which is, if you like, the traders or these types of people to comply with community service agreements, which is about what they will do in terms of quality, about service provision and so on. We have an independent national prescribing service, which is an independent effector of the value achievement arm, which has been critical for us. We have codes of conduct requirements for industry and health professions with effective penalties. We have a statutory quality and safety commission concerned with the issues of quality within the hospital sector. I am a believer in the QALY. I mean, there are people who don't believe in QALY. To me, a QALY gives everyone an equity framework. How do I treat someone with cancer, with someone with migraine? I bring it back to a common metric. And then I put it in a decision. Not simply say, you're up, you're down. And the ability to take into account other relevant factors other than simply the magnitude of the cost per quality. The ability to target those that benefit mostly. The highly regarded regulatory framework. You need to have confidence in the quality, you need transparency, you need accountability, you need stakeholder input, and you need the linkage with quality use. And there are a number of challenges which I'm happy to talk with you before. But as I said, we've got a system we think that works. It's under pressure like anyone else's. I can offer advice, I cannot offer direction. Thank you, Laurie.
If you just take open new, because it was there.
This one, right?
Yeah. Not that it's that important. Okay. Thank you for inviting me. And since I had such a nice introduction from Leonardo this morning, I want to thank Varun Gowrie for being here, because he was very foundational for me when I started to do work on health right litigation. Varun is a senior economist in the bank and wrote a very important book on courting social justice, which dealt with health right litigation. And I'm sure that he will have a lot to say in the discussion. Yes, then the theme that I've been asked to discuss is what Jaime was talking about as the judicial approach, what the courts do. And what we'll talk about is work that we did, a group of us together, and then published in a book last year, 2 years ago, it was 2011, on litigating the health right. And the question was this: is this something that can be constructive in advancing the right to health, or is this undermining attempts at priority setting? And one chapter in the book looks at this most directly, and I did that together with Norway, who is working on priority setting. So we try to sort of integrate the two approaches. So that's where some of this is coming, and the book will be in Spanish in a month, if some of you are interested. So this is part of the reason why this was concern, because what many countries did see was that there were more and more claims for medical, for medicines and other medical treatment going to the courts. And it was rising. It was rising year by year. And in some countries, it was reaching really, really high levels. So, for instance, in Colombia, which saw the highest number of cases, there were almost 150,000 cases in 2008. And this was causing a lot of concern. So people were asking, what is happening? Is this going to ruin the health system and so on? And I want to start by saying something about, if we look into those cases, what are they actually about? What is health right litigation? And it varies a lot between countries and within countries. And if we look at Colombia, for example, the majority of cases are compliance cases. They arise because health providers deny patient services that the health plan entitles them to. Or it's because of delays or poor quality of services. So a large share of the cases regard health system malfunctioning. So it's not really about challenging priority setting, but it might be about sort of not being able to provide what you said you would do. But then there are other cases, and they are more interesting for the discussion today, and they are cases that concern treatment that is not included in the health plan. And this is often very expensive treatment. And these cases arise because patients are denied services as a matter of policy, often with reference, or usually with reference, to scarcity of resources. And these are the cases that is raising concern. But also within this category, there is a lot of diversity. What are seen as the paradigmatic case is where a patient goes to court to claim expensive or experimental treatment for their condition. Or, in other words, treatment that, according to the priority setting criteria, should not have been provided. But there are also cases asking for services and interventions that, according to these same criteria, should have been included in the health plan, but are not. Maybe because the health plan is not updated, or does not take account of relevant evidence, or because there are good reasons. And that's, of course, another question, because there are good reasons to challenge the criteria that are in place in a particular country. So some of these cases are brought, or because there is no system in place. Some of these cases are not brought by individuals, but by public interest litigation, asking for changes in policy to provide, for example, cost-effective services for preconditions of health, food or water, or medication that the government is denying. And sometimes it's denying it to groups who are vulnerable or stigmatized, such as prisoners or people with HIV/AIDS, or in some cases women. So this is a way that the system can use principles of the right to health to also judge not only in terms of to judge to correct the system in terms of the right to health, not only in terms of the individual's right to health, but also in terms of the way in which the system tries to treat the right to health of the system as such, or of the right to health in society. Because that in many ways is what priority setting principles and systems try to do. They try to make the right to health in society more of a reality. So what we see that litigation does is is many different things. And that's the first point I want to make. It's a very diverse phenomena. People litigate for many different reasons and challenge the system in very many ways. And some of these or many of these are unproblematic and needed from a public health perspective even. And some are crucial from the perspective of the right to health. But at the same time, there are cases that present problems and that do work contrary to the need to set priorities fairly in order to advance the overall right to health in society. And that is, and sort of the underlying question that I'll try to answer is, how can we distinguish between these and the others? And how can the judges distinguish between these and the others? But I want to make another preliminary point, which goes back to some of the things that have been said already, but that's important to keep in mind. And that is that litigation is not the only way that people challenge priority setting in health. So even if you can get people out of the courts, the pressure will be there, and it might take other forms. And some of these forms might be more problematic. The courts are not creating the pressure. And I would just point to what, in my view, is the combination of factors that cause this widening gap between what's medically and technically possible on the one hand and what is financially viable. And this, as we said, is widening in all societies and leads to reactions everywhere. In Norway, where I come from, and where we have a lot of money to put in the basket. And I think everywhere, it's caused by a development in medical technology on the one hand that creates more and more services, often very expensive services, for more and more illnesses and ailments. At the same time, the development of information technology makes knowledge about this more and more accessible to people everywhere. Sometimes and people are aware of things that maybe could help them with their very serious conditions in a way that wasn't there before. So the demand is increasing even more. There are also strong commercial interests involved that fuel this, of course, the pressure. And there is also, and that's also why litigation has become more increasing, I think, is that there has been a development in terms of a rights revolution, where people are becoming more, where the norms regarding the right to health is more firmly established over the past decade in international treaties, in national constitution and legislation. And this awareness also contributes, it can go two ways. It can go into health system and planning, informing healthcare planning, but it can also go into a sense of entitlement to everything that you need or think you need in terms of, at the individual level, in terms of your health. And that's where this balance becomes difficult, and that's where one of the things I think that are fueling this pressure, not only in courts, but fueling the pressure on health system. On the other side of the coin, of course, there is the financial crisis that's contributed to the need to contain costs. But it's not only that. I think that particularly as we move towards universal coverage, and that is sort of part of the context for this discussion as well, if we move towards the universal coverage, and when the right to health in society becomes important, then the need to limit costs increase even more. If the health system is for the few, an extra service added is not necessarily so expensive, but the more people that are included, the more the pressure increases. Now I realize that I'm talking, I have too much, so I'll jump. So we see these pressures, and we see that in Norway people will march in the street, they will go to the media, they will lobby politicians to get the services that people go to court elsewhere. So, and people generally go to court, where you want to go, whether you go to the court or elsewhere depends on the nature of the health system, whether there are effective mechanisms elsewhere for addressing the concerns. But of course it also goes to how much it takes to go to the court and what you can expect to gain from it. And that's where systems differ a lot. we see that the systems where, the countries where we have large amounts of people going to court is where it's very easy to access, where you don't need a lawyer, there's very little cost, decisions are quick. And we also see that people go to court, and that's when individuals can go to court. And that's what we see happening in Latin American countries, that where individuals goes to court and where each individual will get before the judge, and the judge will say that generally give it what is asked with reference to the need to provide it due to the right to life with dignity. But in other countries, courts have dismissed high-profile cases. And one example that I will give is from South Africa, where the Constitutional Court, in its first case on access to health services, ruled against Mr. Subramuni, who asked the court to grant him access to dialysis. The court, while acknowledging that Subramuni would die quickly if the dialysis was not provided, nevertheless found that given there was not sufficient resources to cover the need of all patients who needed dialysis, they had to avoid the temptation of becoming a queue-jumping institution. So what they could do, and did, was to probe whether available capacity was utilized, whether reasonable criteria was in place for selecting patients, whether criteria were followed in the case. And when all were answered in the affirmative, the court found that they couldn't privilege Mr. Subramuni just because he came to court, because it meant that they were failing others with stronger claims, the patients in the waiting room that we heard about earlier. In other cases, the same court has, along similar lines of reasoning, ordered the government to change its policy to provide treatment to particular groups, such as HIV-positive mothers and prisoners. So, what we see in these cases is that the impact of these cases are very different in the different cases. I just want to turn quickly to what the impact is. And what we did was, to partially answer this, we analyzed medication provided by through court cases in Costa Rica, Colombia, and Brazil. And we used priority setting criteria, but we used a combination of the approaches that Jaime was talking about earlier. We looked at the effectiveness of the treatment, the severity of the disease, the cost effectiveness, and the quality of the evidence. So we did sort of combine this to say something about how does the court decisions fare if we compare it to priority setting criteria that you would otherwise use in another system. And we put it into priority groups. So you don't get one figure, but you get scores. And we looked at the medication that was provided. And what we see if we look at the Costa Rican cases, which is one of the countries with most litigation, we see that most of what's provided is low priority, according to this score, which means that it is what you normally find is that yes, it is usually for serious diseases, but it is marginal gain at very, very high cost. So it doesn't say that you should not never provide it, but it says that it is in this category where other types of priority setting would normally give another result. What you do see, however, is that if you look at the early cases, it's often it has often been for more serious diseases that should have been prioritized. So what we see is that litigation can have the results in different cases, and we find similar figures for the other countries that we looked at. So I just want to say one more thing before that I think is important. Okay,
Yeah, the first one.
Why do courts have such a difference in approaches? And what we generally see that in some countries, judges are more can more take the consideration of other into account. Sorry. And so if you know that your decision is going to have a general effect in a common law system, you're more likely to take others into account. If it's a public interest case where you know that this is going to have a direct policy effect, you're more likely to take others into account. So the question is whether it's possible to also make possible for judges to devise strategies, even in individual cases, when you have, given that there are so many other benefits from having accountability mechanisms through the courts, whether there are possibilities for making a system where judges can take, by utilizing perhaps priority setting mechanisms and information, take the consideration of other patients into account, even in individual litigation cases, particularly because many of them have policy effects in the system in indirect ways. So the conclusion then will be that resistance to priority setting take many forms, and litigation may not be the worst, because at least there is a way for people to argue the different cases and rational decisions to be taken, and also that access might be more equal than in other types of pressure. The right to health litigation serves many purposes. Only some of them is a challenge to priority setting. And also that protection of the right to health take many forms, and litigation is not necessarily the best way to protect the right to health.
So, thank you. Do we have a wireless mic? Oh, thank you. There is one here. Thank you for your presentations. We were having three very interconnected discussions. We were having a discussion of the different technical approaches to setting priorities. The second probably was what institutions could be put in place and how they connect to other areas of the health system when it comes to setting priorities. And the third city, it seemed to me that it was how this priority setting in health relates to society as a whole, and how can society react to hold priority setters accountable if they do not, if societies do not agree with the final decision. And I want to open up the floor for Q&A, but I want to take the priority of being the first one to ask you a question. All of you come from developed countries. And as you rightly put it, Lloyd, this is very context specific. But you, Jaime, also showed a map that clearly articulated the fact that most of the countries in the developing world particularly haven't chosen any of the three technical approaches that you discussed. Many of these countries are facing NCD rise now with the cost implications that you described, Lloyd. Then my question to each of you is, what would be the very first thing that these countries, the very first next step forward that these countries could be thinking of when it comes to establishing priority setting processes and or establishing accountability mechanisms for these processes? Jaime?
Look at me. No one there. I think that's the real challenge in the sense of priority setting. I find extremely challenging one no matter what country. I don't think you can ever set a priority setting in the sense of without the community telling you what they see as a priority. So it's a social priority, and because it's where I have difficulty with priority setting at an individual basis is that people, even if you give a scenario analysis to people, they will give different weightings of priority. Mm-hmm. And if you look at what's come out of the citizens' juries and about end of life, about these ultra orphans, the citizens' juries were completely split. So at some point in time, someone's going to have to make a judgment. You cannot have a checklist for priority. So that's the first thing for me. So you've got to have, what was their first advice, is to set up institutions or frameworks where at least the society has the opportunity to lay down what it considers to be its priorities. All right, that's the first. And if you don't have that, then there's lack of transparency. So whoever makes the judgment call can be held accountable. You didn't ask us. So the first thing, my thing is, you've got to ask the society what they consider factors which decision makers should take into account, and what weighting the society relative weighting the society would tend to place on those. So you've got to set up the framework for it. I think that's the first thing. And the accountability issue, I think, is where the real difficulty comes. Transparency brings accountability. I mean, Amy said that we need transparency, and that's absolutely certain. But transparency will bring accountability. But in some of these, I don't believe that there will be the black and white issue where the committee ignored something that the society said was a priority for them. That's where they're held accountable. Others, a group of representative people who've got to make a judgment call. And I think, the issue is, this is what this group did. We took into account these issues. This is the way we weighted it. In the end, we made this judgment. Now, you can hold me accountable. Replace us with another team, and you might get a different answer. I mean, the judiciary system, which has been going a lot longer than the health systems in the world, that's the way it's worked for years. It works on precedents. It works on, it's like I'm charged with murder. I go to the court and I have this jury and they find me guilty. And I said, no, that's only 1 out of 1. That's not fair. I want a new trial with another jury. Then it's 1-1. Is it best of 3? Is it best of 5? Is it best of 10? I mean, I'm just trying to be pragmatic in the sense that at some point in time, there's got to be a group that reflects society's priorities, reflects society's weighting, but makes a judgment. They should be held accountable for that, but not damnable for it. Do you know what I mean?
To follow up on Lloyd's points, I think that what's most important for the right to health in a society is to have a rights-based approach to the development of the policy, because that's where the big issues are going to be. And I think then that means that you have to take participation really, really serious. You have to enable different groups in society to participate throughout the process. It's not going to mean that everybody agrees,
No.
but at least the more the different groups, the fewer groups that can say we were not even entitled to a voice, the more likely you are to have a policy that will have some level of social legitimacy. And then you have to realize that this is not going to be static. You'll never, this is something that has to be ongoing because, and particularly in health, because as health technologies develop, as sort of societies change, as values change, the priorities are going to be different. But then, so I think, and then technological evidence, including economic analysis, has to play a part in that, and you have to, and also has to be something that is brought out and brought into the priority setting process early and sort of continuously.
Thank you.
Yeah, I think a country, you asked, what should a country that's thinking about doing something, how should they approach this? I liked a lot of what Lloyd said in terms of the difficulties in defining value and in being pragmatic about it. But also you said that it was very important to do something that works for you locally, that you can't just implement somebody else's system. I think that I would want to really highlight that. There has been some imperialism in methods being practiced,
Yes.
and I think that's a very bad idea. I think just adopting what somebody else has done is not going to give you satisfaction. The rights-based, the idea of a right to health has troubled me since I first heard about it, because I don't understand what it means. I understand the desire to use the human rights system to bring more health to people. I get that, but I don't really understand what a right to health means. What does it actually guarantee a citizen. And I think until you define that, it's a risky proposition to base it on the right to health without understanding what exactly that means and how to implement it in any kind of technical format. I think we do need technical approaches because there are lots of facts and numbers and uncertainties that need to be processed, but we can't be driven by those technical systems. They can only provide information to the decision makers, which ultimately have to try to integrate that very difficult to quantify value idea.
Thank you, Jaime. Siri. Any questions? Let me take this. May I ask you to come to the mic just because we are being webcast and we would like the audience to hear your question as well.
Mine is not necessarily a question, but it's a comment to Jamie. When you say you don't understand really the right to health, I'll just give a case in point in Uganda, where we have a population that 88% of the population in Uganda lives in rural areas, and many of them do not even know what they're entitled to as citizens of the country and what they need to hold the Ministry of Health to account to. So, for example, one of the civil society organizations which has been sensitized in the rights revolution, like you mentioned, came up with a patient's charter. They worked with the Ministry of Health to design a patient's charter that basically they use to educate the population on what they need to be entitled to. For example, when they go to a health facility, they're entitled to the following. They need to be seen. If they do not see a doctor, then there is an issue. Or if nobody attends to them, then they need to know how they need to even be treated at the health facility. So those are some of the very basic fundamentals of the right to health. And maybe you can add on, to say just some of what you don't understand about that part. But from an African perspective, we definitely need the education on what a citizen is entitled to. Yeah, thank you.
Can I comment? I think that's absolutely right. But the issue is that's enshrined in a fundamental right. All right? That's a fundamental right of everyone to be treated equally and to have access, and for government to have some affirmative action, if appropriate. I think that to me is a no-brainer in that sense. However, I share Amy's point to some extent. If this person in the judicial thing, which I've always, the more I hear about it, the more nervous I get, and I'm raising it home and saying, let's not go this track, let's not get anywhere near this, because one of the issues that to some extent, not so much in basic services, the right to a package, but this is, a new drug comes in that's going to cost, $100,000, and in a fixed budget, something has to drop off the end. Now, when does this person's right influence this person's right to maintain what it has, he or she has, down here? And does the judiciary think about that relative right, about, that's the package, and now I want to add a little cube here, and to get that, I'm going to cut out a little piece out the bottom. Do I ask that person what their right is? I might say that this drug comes and it provides better value, a big value for a small number of people. What my place is something that has a lesser value, but has to treat more people, and that's a tension to me. And I do
actually,
not
when it's green here, it means you can be heard. When it's red, they can't hear us.
Why is it?
Okay. So I think the issue of human rights equals health
Are those
rights.
people there?
I don't know. I think it's just a different thing.
Can you say that they should not talk?
Can you please, colleagues in Nairobi, can you please shut off the microphone for us? Thank you.
Teresa, can you hear us?
You can look at the
Hello,
things.
Teresa.
Yes,
We are
I
still
can
in the
hear you, Yvonne.
Yeah. We are still in the session before yours. Can you please mute your microphone because we can hear your
sorry.
discussion?
Sorry.
So once you finish, Lloyd, and before Siri goes ahead, I would like to collect 3 or 4 questions that I saw, and then I pass on to Siri.
Okay. To follow up on the question, I think, or on the answer, I think that there are of course, there are different views of what the right to health entails, and that is, of course, also why it goes to different approaches. And I think that if you look at the sort of a common way of of phrasing it is that it's right to the highest attainable standard of health, progressively realized within available resources. And then the question is whether this means that there is a minimum core that is directly justiciable or not. And I think that the Latin American approach has been to say that there is at least you can see it this way, there is a minimum core and it's big. It's basically everything. But for instance, the South African Constitutional Court has said explicitly that it doesn't go with the minimum core approach. What it does is that it says that the right to health, which is in the Constitution as well, very phrased in the same way, does commit governments to prioritize health, to prioritize sort of the right to health when they make the budgets. And or that's, I guess that's what it has only said in weak sense, but also that that it means that different patient groups have to be prioritized, and that it places limits on what the government can do with regard to the right to health, and that the courts have a role in making sure that the government is within the limits of what the right to health says, but within that limit, it's the government who has to make the budgets. And then in Colombia, it has also said that it means that when you make health reform, you need to have a participatory approach to the reform to make people heard. So there are different ways of looking at it, but I think that one way that is the more courts are saying are sort of trying to say is that it means that you have that the right to health is the right to have just health system.
But can I just raise a spectre if I can? It's the issue of where the equity framework of that comes from.
Yeah.
Because some people might be encouraged or facilitated to go to judiciary.
Yeah.
Those with the biggest voice may not. So I just want to raise an issue about right to health and equity. How do you maintain that in a pragmatic way?
Let me grab 3 questions. Can you please come to the microphone? Or we can repeat it maybe. Or we can repeat it. Can you go ahead, please? You can say it and we can repeat it from here. Your question.
No, well, I was actually, I think what Lloyd is talking about is extremely, I mean, we do some work on this issue, and I'm wondering from this expert panel, I came in a little bit late, so maybe we didn't discuss it before, but what would you advise on this trade-off between, well, it's not a clear trade-off, but the right to health and equity, like what, and also from how you have seen this develop in countries where you have sort of reached an outcome that's favorable, both from a right-based perspective and equity perspective. How did they go about coming to that outcome, if you look from like an historical perspective?
Just to repeat it, and before I collect the other questions, what would be the trade-off? What would you advise, Lloyd, if there is a trade-off between right to health and equity? Sir, then Varun, and then I go back there.
Just a clarification question to Jim, because you, for the priority setting, you mentioned 3 methods, which will be classic, and you have clinical approach, economic, and judicial, and then you proposed need-based approach. I was struggling to see how it's different from, for example, clinical approach, because who defines the need?
Jaime is being asked if he could further clarify what is a needs-based approach and who defines the need and how that approach differs from a clinical approach. Varun, then I go back, then I go to Roberto.
I have a couple of points.
Please do.
I have 2 quick points on the right to health and then a question for the panel. On litigation, what people often think of as judicializing something is when a judge makes a final yes or no decision about a question. And that, I want to make the point that that is sometimes what happens in right to health litigation, often in a place like Colombia, but oftentimes that's not what happens. Oftentimes judges create commissions, they create modes of inquiry, they invite input, they do ongoing monitoring. So what they're partly doing is exactly, when it's done right, and obviously there's corruption everywhere, but when it's done right, it speaks to Lloyd's point about creating a group of representative people to provide input and to make a decision. And then to Jaime's point about what is the right to health, my favorite definition is from Henry Shue. It's about a justified claim that the actual enjoyment of a good be socially guaranteed. So it's it's sort of saying that society ought to guarantee something. It doesn't say how it ought to be guaranteed. And it's for the whole society. It's not for one person necessarily. But it's really no more controversial, in my view, than, say, the right to speech, which we believe in. What's speech? You have a lot of people arguing about that for a long time. There are exceptions, there are rules, but still there is a place for that kind of claim in a society. And I think it speaks to the kinds of things that were, the very values that Lloyd was mentioning. So those are the comments. And the question, which is, in the presentations, you've taken the price of pharmaceuticals as exogenous, right? But we know it's not in reality. There's bulk purchasing, large negotiating. You know, when you have one large purchaser, you can lower prices. You have spillovers between countries. And I can understand from the point of view of a purchaser, they don't really have control over that. But really, from the point of view of how society ought to be organizing it, those are really the same decision. I mean, outside there's a market perhaps, but that market isn't perfect by any means. You know, if there were no single purchaser, you still wouldn't have a perfectly functioning market because of patents and intellectual property protections and because of things like the economies of scale and production. So if you think about things like purchasing things in large bulk or in one purchaser or compulsory licensing, should that be folded into the discussion? Because it's all about access as well. And does that affect your thinking?
Thank you. Before I take the next two questions, and I would like to ask you if we are just running 5 minutes to the coffee break. So I would like to invite you, if you want to bring your coffee to the room. We will break this part of the session at 5 before 11, so we transition to the session in Africa and access to medicine. Okay. So, and the coffee will be served in 5 minutes. So please.
Okay. My question is right to health. Does that lead to an obligation on the World Bank side? In the bank, we make very strong arguments, you know, for a basic package definition on the basis of strict economic arguments. If you take the right-based approach, would that make a big difference for us?
The question that was raised in the table, and again, I'm repeating this for the benefit of our audience on the internet, is whether a rights-based approach has any, implicates any obligation for the World Bank as a development institution. And Roberto?
My question goes to the how to make it incorporation of values into the decision-making process. You know, I think all of you mentioned, in the end, these decisions are value-based. We can add technical elements, but in the end, there are a value judgment element as part of this process. But we know that values in society are also influenced by other factors, external factors, like media or, you know, lobbying and whatever, you know. How do we take that into account? And, you know, and that values are not unduly influenced by other forces, economic forces, whatever. And also, how do we operationalize? How do we know, especially if we're talking about weighting, how do we find out what are the weights that society puts on things operationally? How do we do that?
Roberto asks if we are to use values as one of the criteria, how do we make sure that these values are not unduly influenced by external factors, and then how we actually operationalize values within the decision making. I have one last question, Lloyd, for you. Why did PBAC use different actors in their composition? Why did you had a slide that showed that PBAC members came from different actors. Why did you make that decision in the first place? And then Jaime, please, let's start with you.
So briefly, there's a lot of questions on the table. To the right to health clarification, I appreciate what you said about Uganda. You're defining it as a right to basic services. Not quite sure how that equates with right to health. It's a right to basic services. To the idea that right to health is the same as right to speech, that they're analogous, I don't agree. Speech doesn't cost anything generally, and it doesn't impinge on other people's right. It doesn't compete. It's not a competitive issue, so both can speak, whereas this right to health involves the competition that I think Lloyd brought. So I still remain confused about what exactly right to health. Sorry? Campaign finance is part of the right to health. We can cut it finer, but the basic right to speech is grantable without impinging on other people's rights. The definition, actual enjoyment of a good should be guaranteed. I have no idea what good we're guaranteeing. That's my problem. I don't understand are we guaranteeing that my glasses can be taken away because you fixed my sight? Are you guaranteeing the fact that my wrinkly skin is going to get better? I don't understand where it starts and stops, that right. The differences need-based to clinical, perhaps we can leave to the break and I can go over it. I think they are different, though they're closely related.
Can you give an overview of that?
The pure clinical approach does not rank things according to the need. It says, does this work for this condition? Does this thing work? It does work. Okay, we need to negotiate a price for it, which is where the pricing issues that you brought up come in. In France and Germany, they negotiate the price. It happens in the U.S. in the veteran system and in lots of systems where they first assess whether the thing works and then decide, okay, how well does it work, and use that as the basis for negotiation of price. So the difference is the needs-based approach would incorporate some sense of how important is that service to our society. Then I have no idea whether it commits the bank to anything because I don't know what the bank's commitments are, so I can't comment on that one. Operationalizing the incorporation of values into society, we need a couple of weeks to discuss that one. There are many ways in which this is done. How do we operationalize whether we should fund the army or not? Well, different systems vote on it. In Switzerland, you have the cantons voting on things. We elect representatives to make the choices for us. We have a dictator who makes the choice for everybody. Humans have explored lots of ways of doing that. I don't think health is all that different in terms of how we might operationalize those. And the last one was a specific question too, Lloyd.
Sure.
I want to start with Brazil. I think that Brazil is a very interesting case to me because if you look at the way the right to health is phrased in the constitution in Brazil, it's the right to a fair health system, basically. And then if you see the way the courts are now implementing it, it's very much as an individual right to treatment for anything, basically. And that's quite interesting. And I think that there are a lot less problems with interpretation that the right to health is the right to a fair health system. And I think that is also where courts have been taking the very important approach that Varun was referring to, which is to say that we can't say what this is in this particular case. And sometimes they can say that what is currently happening is an unconstitutional state of affairs because there are things, or this situation is in breach of human rights for a number of reasons, and very importantly often because it is discriminatory. And I think that is, non-discrimination is a very fundamental principle when it comes to human rights and the right to health, that if you provide something, you should provide it to those similarly situated and with similar claims. And I think that is also, and I think that is but also that the right to a fair health system is also, as I was saying earlier, it's also about process, that it's also about giving people a say in when it comes to developing the health system and maybe setting the priorities in the health system, because I think it's that participation is always very participation in terms of what is adequate health services, what is accessible health services, what is quality, what are values, are very important because it is also something that is very much linked to the values of society. And so I think that I would sort of see not rights and equity as conflicting, but more as linked to one version of the right to health more than others. But I think that what is also important, and why it's also important to have an individual right to go to court to claim, is not to a right to anything, but to see whether you've been fairly treated, whether your special situation has been taken into account, and that is something that's important to take care of. If you can hinder it from undermining the policy as such. Yeah, and I think that in a way that also goes to the question of what this sort of what a health-based approach would mean for the World Bank. I think that it does mean that process will have to be taken seriously in terms of the creation of health policies in different systems, that in different countries, that is something that then becomes really important. But also looking at whether the system, how the system functions in terms of various types of groups, and particularly in terms of vulnerable groups in society, because that's how you can see the discriminatory qualities.
Thank you, Terry.
Can I raise a number of issues? Right to health, I heard, and I've heard a right to health system. They, to me, are different. I accept there is always a universal right to a health system, and that health system should be quality framework. But that's different than a right to health. It's a right to health system. If the health system says we are not providing this drug to anyone because of X, that's the system. And it does. And so if I live in the city or I live 1,000 kilometres, if the system says yes, I should have access to that. They're that system. And so I think there is a difference between the right to health system and a right to health. Because the right to health may mean better sanitation and water. All right?
Yeah,
it may not be good. It may be, the fact is that impact on health. So that's first. Issue about, go to the first question around the right to health and equity. Given the right to health systems and equity, one of the things that worries me, what I've seen in South America, and this is from an external, superficial viewpoint, what I've seen. I haven't been there, so I don't know the system. But what I hear is that those that you're loudest and are more organised and are in partnership with a third party that would benefit from that, that is a drug company, they will have a greater access to the judiciary than people who are not so. So in other words, the access to judiciary has got to be equitable. If you're going to have the right to judicial system, you've got to have a framework or a system which is independent of third parties, where people can complain to like a commission that will then go to judiciary. To simply have this randomised approach, which I think what I hear is real fraught with inequities, and those who shout loudest with the biggest pocket of money are likely to get action when those that do not have those attributes are likely to fail. So if you're going to set up the approach to the judiciary, seems to me it's got to be via a common pathway to which everyone can have access without the capacity of financial input. Because if you don't do that, it seems to me it's an elitist approach to right to health. The issue around, I think, the judiciary doing more than saying yes or no is absolutely right. But what they're reflecting, I think, is the absence of appropriate systems and processes in place before I got there. So they're really saying they go, set up the processes, set up the systems, set up the transparency. I think that's the beauty of it. But a lot of that would be reduced, I think, if we'd thought about what systems and what structures we need in place first. Regarding price, you better believe it. I do not know what a fair price is. What's a fair price? That's what companies say, we want a fair price. And what do you mean by that? How much you can get out of us for your shareholders? I mean, the answer is I don't know what a fair price is. And price negotiation is absolutely critical. And in terms of the developing countries, the work I've been doing for WHO is the major impact on health in the developing world could be done by quality products of generics and a framework that convinces the consumer of their quality. They're deliverable at an affordable price, which is the price arrangements. I think that would have the biggest impact on the right to the health developing people. The more I look at the issues around the lack of impact on health in the generics in the developing world, it's less than it is in my country, in many cases. Some countries have got it right, many other countries are really struggling that issue. The issue, Roberta, about how do you incorporate values, I would strongly advise you to look and keep watching on the value-based pricing concept that has come out of the United Kingdom, and what the Department of Health in England has just commissioned and has commissioned and got a report back from Claxton from the University of York, where they've gone out and surveyed, I don't know, 36,000 or 3,600, I can't remember what is the biggest survey ever, about weightings, about preferences, and what they have given the government, what University of York has given the government, is an algorithm. All right? An algorithm for weighting and for preference setting. Now, my concern with that, as I expressed last week in London, was, A, it doesn't take into account comorbidities, and they ask a single scenario where, certainly in my country, 65% of the utilisation is in people who've got more than 4 comorbidities, and so they will trade off within their comorbidities. That's the issue. But it is coming, and one of the concerns I have with it is an algorithm. It's a black box, but it will still require judgment. All right. Why did PBAC have a composite membership? Well, that's all stakeholders should have a right into the decision process. But you need people who've got certain expertise. So you need the clinical expertise, you need the technical expertise. So you need economists, you need clinicians, you need consumers. The question is, do we need industry? The answer is no, because they have a vested interest. But in the UK, industry is represented. Okay? We have consumer representatives on all our committees, all our subcommittees. They are full voting members. In France, I think they have them, but they can't vote. In Germany, that's the new German system, recognise consumers, but they have no vote. I think that's an insult. And I've said that to the people from ICWI last week and GBH. I mean, why would you do that? Why would you bring in a token consumer? So, there are issues in Australia about whether we need more consumers. I don't know. I think that's an appropriate debate that goes on, but it should be, representative.
Just to try to answer your question, last November, in a meeting in Salzburg on the right to health, the president of the World Bank, Jim Kim, stated, we fully embrace the rights-based approach to healthcare systems. What does that do to your question? We'll see that he stated that. Thank you, Lloyd. Thank you, Ceres. Thank you, Jaime. Thank you all for being in this session. Very useful, very provocative as well. Thank you so much.
Thank you very much for fantastic presentations. I could stay for a long time talking about it. I had all my things, my notes. I want to know if people are going to bring their coffee here, so we start with the next session, or if you need a little break.
I think it's a 5-minute break.
5 minutes. Okay, let's do that and just do a 5-minute break and we come back. Okay, terrific. And can you let them know, the people on the screen also, so they don't suddenly think that what happened?
Hello, Kenya, can you hear us? Can you hear us in Kenya?
Where you are trying to pop it.
Let's make sure that the Kenyans...
Yeah, we just tested them. They couldn't hear us. It's Humber, the guy in the black keys.
Okay. Yeah.
For both the same thing.
Yeah, I'll do everything. Just hand over to me and I'll take it from there. Let's just try to make the link.
I was looking
So outside we were expecting him to leave so she could get me. Said that, well, if we're not starting, we will leave.
No, you're starting.
So if you can make the link between the pen and, what we're going to discuss.
Okay.
Thank you.
Should I sit here, Julia?
No, no, no. You know what we discovered with the first panel? There's only one mic in this room, which is this one.
That's a mic.
Is it? Yeah. Okay, then that's how we could hear these people. But we can't hear any of the questions of the people.
Yeah.
So they absolutely have to come here, or somebody has to repeat their questions because it's quiet. Like it's we can't hear anything.
So these are speakers, but they're not mobile.
Yeah.
Can I let me sit here?
And then can you repeat? And then you repeat the questions when yeah.
Where are the people from? No, it's just these two. Where is that?
I was thinking all the time about
I think that's okay. The needful markets are the ones that which are interesting, and then we also oh gosh, now I can't find myself.
Julia.
In a way, I work on posts, I used to sort of work on the different posts as well.
I see.
That is
They're trying to unmute the Kenyans. Kenya, can you hear us? Can you hear us, Kenya? Do they look like they can hear?
Yes, we can, Julia.
Oh, perfect.
Julia, can you hear us?
Okay. Yes, yeah, we can hear you. We can hear you, Teresa. Just to give you a little bit, so where the because of the location of the mics, you may not be able to see me. Can they see me? No. Okay, because of the location of the mics, you won't be able to see me or any speaker that's talking from this podium. That's because we only have one mic at the podium that we can use. But you will be able to hear us. Okay. So if you don't see our faces, don't panic too much.
That's good enough. That's fine.
Oh, can you see us? Hi, Daktari.
Hi. Hi. Hi, Yvonne. Hi, Yvonne. Very fine.
Okay, we'll start very soon. We're running late from
Okay.
Yeah, we're running about a few minutes late, so please bear with us. We'll start soon.
All right. All right, it's fine.
Yes.
Are you sitting in the front?
Yeah.
Bob and what was it about this? And yes, yes.
Oh, you want to be here? Okay. Jill, you can sit where we but no problem. I don't mind at all.
Yes, yes. I think so.
Peter, you're here. I put you next to me. Your other session.
They took so long.
Yeah. Just sit, yeah.
All right, we're going to start the second session, which is a very good continuation of the discussions that were happening in the morning. And we heard a lot about the different, the clinical, the economic, and the judicial, and a lot of discussion, what is and what is not a rights-based approach. But I also heard that they were all talking about the need for transparency, for accountability, and Lloyd was saying that it is very important to have a very good distribution system. And there was some conversation about that in some countries, prices are negotiated and agreed upon. And Lloyd made a comment on the role of the citizens. And he said, well, citizens are invited, but in some cases, citizens don't have vote. And he thought that that was really also something very bad. So I think that in this next session, we are going to hear the experience of the work that WBI has been doing with our clients in Kenya, Uganda, and Tanzania. And we are learning from them and from their experience how multi-stakeholders can be together and discuss how can they improve the distribution and the procurement of basic pharmaceuticals to improve access. I leave it with Yvonne, who is leading this work for us. Thank you.
Thank you, Maria Luisa, and thank you all for coming. Can I kindly request that you move to the front of the room? There are lots of empty seats here, and you're all at the back. Come closer so we feel we're having one meeting. Hi, Andreas. So we had this morning, okay. get people to settle down. Patrick, you want to move? It's a problem when I know your name, Evelyn. So we've heard a lot this morning about the right to health and access to services with, a touch on access to pharmaceuticals. So, and I just want to start with this opening slide on pharmaceuticals. We all know these are very basic facts that we are all aware of, that pharmaceuticals are the largest public health expenditure in many low-income countries. And given the volumes that we buy and given the people that we still have to reach, WHO still estimates that 30% of the population still lack access to basic essential medicines. So we're not talking about, some of the sophisticated treatment that we heard about this morning. We're still talking about very basic pharmaceuticals on the essential medicines list. And yet, if you look at the statistics from Transparency International, it says that 10 to 20% of procurements are lost. And all of this is associated with corruption, inefficiencies, and what have you in the system. So how do we do more and better with the limited resources that we have? Could greater transparency and accountability in pharmaceutical procurement and supply chain management contribute to improve outcomes? And what is the potential for collaborative action in effectively addressing these challenges? So we are not asking for more money, and we recognize that there are many barriers to access. But what is it in the field of procurement of pharmaceuticals? What is it that we can do so that we get more for the limited resources that we have? How do we strengthen and make sure that we have transparent, efficient systems so that we can even make a claim for more money? Without strengthening the systems, without being transparent, without holding governments accountable, we can ask for more money, but it's like going to the farm with a leaking bucket. You have all the water, but by the time you get to your crops, you have nothing to put on the crops. So, in 2010, WBI launched through a very extensive consultation process. I can see a lot of the people that we talk to here. We talk to people inside and outside the bank to launch an initiative intended to address some of these issues. The Pharmaceutical Procurement Initiative facilitate the development of multiple stakeholder groups consisting of government, civil society organization, and private sector to forge consensus on key challenges in PSM and to outline joint strategies for improving greater transparency, accountability, and efficiency, hoping that if we're able to stretch the limited resources that we have, hopefully we'll be able to reach more people with medicines. Oops. Let's go to the next slide. Anyway, so why a multi-stakeholder approach? And I'm sure you're all wondering, a lot is being done by different partners, including the bank, to strengthen PSM in a lot of these countries. Why do we want to look at a multi-stakeholder approach? What are the benefits? Why do we want to create a safe space for government, for civil society, for development partners, academia, and all those who have a stake in procurement? For all those who have a stake in the access agenda to work together. Often you have civil society doing their own thing. You have the private sector, which is also doing something very similar to what happens in the government sector, and yet they don't talk to each other. You have the academia, you have the media. What is the role that each of them can play, working together to identify the governance issues in the system, work together to agree on joint solution, and be held accountable for implementing and strengthening the systems in their country. So we're basically trying to move from a place where all the actors are in different silos to create a safe place, an enabling environment, to build capacity of the different stakeholders so that they're able to work together, create a level playing field for effective and constructive dialogue, and forge consensus across the group to strengthen the systems in their country. To discuss the benefits, opportunities, and challenges, as well as achievements of applying a multi-stakeholder approach in promoting transparency and accountability in pharmaceutical procurement, we have assembled a distinguished panel of speakers from each of our pilot countries, representing civil society, academia, and government, to discuss what they are doing in Kenya, Tanzania, and Uganda. Let me start with our colleagues who are joining us from Kenya. Unfortunately, I can't see them from where I'm standing, but it's very late their time. And I'd like to introduce Dr. John Munyu, who is the Chief Executive Officer of the Kenya Medical Stores, KEMSA, which is a state-owned enterprise mandated to procure, warehouse, and distribute medical supplies to all public facilities in Kenya. He's a supply chain management expert with over 18 years of experience in public health sector and has spearheaded major reforms within KEMSA. With him is Teresa Omondi, who is a lawyer with over 10 years of experience in governance and human rights. She's currently the Deputy Executive Director of the Federation of Women Lawyers Association in Kenya, FIDA, which advocates, among other things, reproductive rights for women. She's one of the founding members of the Kenya Forum for Transparency and Accountability on Pharmaceutical Procurement, which is the local multi-stakeholder coalition in Kenya. The coalition in Kenya is hosted by Transparency International. Can you hear me, our colleagues in Kenya?
Yes,
Teresa,
we hear
can
you.
you hear me? Good.
Yes, we hear you.
Thank you. To our panelists in the room, let me start with Peter Okwero, who most of you know. Peter is a senior health specialist at the bank, and that's all he wanted me to say about him. And he's a TTL for the health sector program in Uganda. Representing the private sector is Jacqueline Idisu, who is a pharmacist and a key account manager for MEC in Uganda. She's also a member of the Technical Working Group on Medicines Procurement and Management convened by the Ministry of Health in Uganda. Proud to join MEC, she served as the national coordinator of the Medicines Transparency Alliance, META, which is also the local multi-stakeholder group in Uganda. Last but not the least, we have Joseph Mahandu, representing academia. He's the Dean of the School of Pharmacy at the St. John's University of Tanzania, which is also the national convener for the local multi-stakeholder coalition. He has extensive experience in pharmaceutical procurement and supply chain management, having held senior positions in parastatal and private pharmaceutical companies and distribution companies. He is also the local facilitator for the multi-stakeholder group. Ladies and gentlemen, please welcome to the session. So we're going to have we're moving away from the PowerPoint presentations that we had this morning. This is going to be a facilitated discussion where we're going to have a conversation to hear some of the experiences, the challenges, and issues around sustaining this multi-stakeholder process at the country level. So I'm going to be asking the questions, which is the easy part, and they're going to be telling us, responding to those questions. And after that, we'll open it up for Q&A. So let me start with my colleagues in Kenya. Dr. Munyu, what are some of the major PSM challenges you face, and how is KEMSA utilizing a multi-stakeholder platform to address these challenges?
Thank you, Yvonne. Just like you said in your opening PowerPoint presentation, Yvonne, just like many other countries, we have a lot of weak systems in our pharmaceutical supply chain. And some of the major challenges that we face in this area, Yvonne, first and foremost is gaps in governance in terms of having limited citizens' role in shaping governance. By this I mean that the citizens, yes, they are there. They do not have enough voice. They do not have the voice. We do not have enough structures and systems of managing the systems within the pharmaceutical supply chain in terms of inventory management, in terms of ensuring that medicines of the right quality reach the intended users or destinations in the right time. And therefore, what I'm really saying is limited transparency and limited role of citizens in having a voice and in trying to shape governance in that area. Another challenge that we do face in that area is also the limited knowledge that the stakeholders have in understanding the pharmaceutical supply chain management. And therefore, due to the limited understanding that they have, their contribution and their effectiveness in trying to shape the direction and the strengthening of the same is limited for that reason. And fourthly, there is also the issue of monitoring and evaluation mechanisms that would help a lot in trying to rectify and correct and identify the weaknesses and gaps. Now, most of those M&E mechanisms do not exist. Structures and systems to enable the M&E systems to work effectively are weak or non-existent in many of the areas. And generally speaking, there is a limited awareness and poor information flow to the stakeholders downstream. That means the stakeholders they have very little information. They know little of what happens. There is a lot of ignorance, and therefore the drivers or the managers of the pharmaceutical supply chain management systems do what they do. They do not have checks and balances in most cases, and therefore there are excesses in that way and the other way, and this poses a lot of challenges generally in having a properly working pharmaceutical supply chain system. In a nutshell, these are the main challenges that we do have, and the fact that also the access to the much needed information systems to deliver that information to the citizens, to the stakeholders, they are not there. And even in many cases, that information does not exist in terms of having credible data available that can be interrogated so that we know that this is what was availed and this is what eventually benefited the beneficiaries. That data, the integrity and the existence of that data is in question. So these are the challenges in a global form in the bigger picture.
Dr. Munyu.
Yes, Yvonne.
How you have clearly articulated some of the PSM challenges that you face in the area of governance. How is KEMSA utilizing the multi-stakeholder platform to address these challenges? Can you give us one specific example on how you are leveraging the expertise and the resources within the stakeholder group to address some of these challenges?
Well, I can give one or two or three examples of how we have leveraged this, and I would want to start by giving a little background that before we formed this forum, which we call FOTAM, the relationship between us, and when I say us, I mean the Kenya Medical Supplies Agency being the biggest national pharmaceutical supply chain organization in the country, was one of an animosity because, well, information is confidential, the data is ours. We know what we are doing. We know how to do the work. And the treasurers of Omodis of those days were enemies and many others. And what we had was exchanges through the press between the civil society, ourselves, and many other players in the supply chain system, pointing fingers this way and that way. But when we got together as KEMSA and the civil society and the other stakeholders, what finally we ended up having is a pool of resources where we have people looking at a problem with different eyes. You look at them with the different eyes of a medic, of a lawyer, of a civil activist, of whatever you are, and therefore by looking at a problem with the different eyes, hearing at a problem with different ears, and reasoning with different minds, we got many different solutions to problems. Instead of the finger pointing, we ended up with solutions. And I can give you an example. We used to have civil society, particularly a group known as the Global Network of People Living with HIV and AIDS, storming our offices, demonstrating you are not distributing enough ARVs, you are not doing that and this. They used to do that. And when we, after 2, 3, 4 sessions, after we got down and we started working within this forum, FOTAM, of course, after breaking down the ice and boarding, we started talking. We started addressing the issues, and I can tell you that the same groups that we used to be like antagonists, they are the same groups that give us vital information about pufferage, about any anomalies that happen in some of the public facilities there in the periphery where our M&E people do not reach. They give us very vital information through email, through telephone, and even to go a step further when we were trying to come up with a new legal framework for the Kenya Medical Supplies Agency to strengthen it. It is the same people who came out very strongly to fight for KEMSA, and now KEMSA has a new legal framework. We have transformed from a government agency to an authority, and we got a lot of support from the civil society. And I can tell you, as we sit here today, and this is the benefits of doing this, there are many things that we didn't know, things pilfering to the other side across the borders, particularly to our Ugandan brothers' side and so forth. And we have been able to stop most of these pilferages
Peter can hear
because
you.
of the information and intelligence that we get from the civil society. So we have started harvesting and seeing the fruits and the benefits, and the same people we thought were throwing stones at us are actually giving us ammunition and information to really strengthen our supply chain systems and bring systems that ensure that the beneficiaries of our supplies do benefit. These are just but a few of the benefits of this collaborative approach that we have, genuine ones and recent ones that we have seen.
Thank you, Dr. Peter, things are being siphoned to your country. As TTL, what do you see as the value added of working? What do you see as the value added of working with a multi-stakeholder group to address governance issues in PSM? Is there really a role for non-state actors?
Yeah, thank you, Yvonne. Now, Yvonne wanted to know why I asked her to introduce me as TTL for health, and she knows that I'm a man with many lives. In my home, they really don't know that I work for the World Bank. They see me as a medical doctor. But nonetheless, I think the experience we have had both in Uganda and East Africa since the creation of these multi-stakeholder groups has been interesting, especially in reducing the suspicion like Munyo in Kenya has indicated, bringing different parties together, but more so what would stand out that one needs to appreciate the constituents.
So, I'm very sorry to interrupt. Could you use the podium because it's hard, it's a bit hard to hear.
I can come down this way. Am I now audible enough? Yeah, no,
yes,
I was
but
saying.
We can't see you.
It's got to be one or the other.
I think there'll be a trade-off.
Okay.
I just wanted to say that it is really important that when we think about these groups, we need to realize that their competence will depend very much on the constituents and also the skills which they bring, in addition to the willingness, particularly from the government side, to share what Munyo indicated, vital information. And I think what we saw in Uganda, where you bring pharmacists both from public and private, legal people, other public sector people, and ordinary civil society advocates who come together. So you end up with the pool, which is really critical. And to me, what was most interesting, and I want to say this because when I joined the World Bank, my first mission was when there was a large team from Danida, the World Bank, and several partners who were looking at PSM. So I was saying, okay, who are these people? And you know, they called for a large meeting, but in that meeting, there were less than 10 people who came, largely because of ignorance, and partly because also the truth is PSM is complex. And many times, the media, the civil society, gurus, don't actually understand the issues. So while they speak, while there's a lot of suspicion, there's also a lot of misinformation. And this generates the mistrust that we have. So one key benefit, I think, which we could easily see when the team started coming together, just like in Kenya, was that the government people could easily identify with these guys once they started sitting down. The advocates who were previously so critical of government became their biggest ally. So when you get NGOs now speaking, they don't speak about leakages without knowing where the leakages. They actually identify where the leakages take place, and they're able to inform the relevant teams. Two, they also understand the complexity around PSM, the underfunding, and then they are able to engage not only with other policymakers, but with the media. Just like in Kenya, because Kenya, Tanzania, Uganda went through a similar process of reviewing their procurement regulations at almost around the same time. The main civil society groups in these three countries, I know in Kenya and I know in Uganda, worked very much behind the scenes to push parliaments to recognize that public procurements of health sector commodities are specialized, and you need to provide the mechanisms through which this can be done. Two, they have also put pressure, and they continue to put pressure in these countries, especially with regard to financing of drugs. If you take a case like Uganda, the government had to come up with a clear budget line for drugs, which now promotes this. This did not come by accident. It was largely because the Ministry of Health obviously had been fighting for this, but without the support of the broader coalition, that wouldn't have taken place. And then lastly, I think what we see is reaching the communities. A key challenge for many government agencies, a key challenge even for local governments where they're decentralized. But you need these coalitions, and especially if they're broad-based and they have networks, that they're actually able to pick out information which they do share, and then they bring to the attention of their main group in the center. There are risks also with these groups, obviously, especially when you have a dominant group, either from the private sector or from the public sector, or you have civil society groups that have different interests. So it's critical that when these groups really together, that you are able to ensure that there is a process which provides for the groups to share and to be committed to common areas, common values, and really able to ensure that the information which they come by may not be used for other purposes other than that of really ensuring that the multi-stakeholder group works towards a common agenda which they all aspire to. But largely the experience has been that they actually do have a very big, they do actually provide a very big benefit when they are well organized and well represented. That would be my observation in terms of the role of the non-state actors, as well as the value that this group does bring on the table.
No, not for now. Can you take your stuff? Thank you very much, Peter. It's becoming very obvious that while this is very useful and could yield some very positive results, it also has its own risk and could be a very difficult and complex process on the ground. I'd like my next speakers, Jackie, Joseph, and Teresa, to talk to some of these issues. What does it mean to build a multi-stakeholder coalition? How do you engage, and how do you reach consensus and move forward? To address the specific issue, I would like Jackie to start by telling us a bit about what the coalition is doing in Uganda. What are the specific PSM issues that they are tackling, and what mechanisms have they used, and what are some of the early successes and challenges?
Okay, thank you, Yvonne. I'll just begin by giving some sort of background to the Uganda Multi-Stakeholder Coalition, linking it with the previous session that we had in the morning, where we were basically speaking about the right to health. And I want to link the fact that we're talking about the right to health and then the relevance of the Multi-Stakeholder Coalition in context. Firstly, Uganda has no national health insurance. There's no national health insurance in Uganda or universal health coverage. And over 50% of all healthcare is sold from the private sector by patients, and that is out of pocket. So what that really means is that, you know, there's no protection for the public, if I would say, because the private sector plays into 50% of more than 50% of the income of the public is, you know, out of pocket. So there's definitely a need for watchdogs for the public, because in countries where you do have a national health insurance, there are processes to take care of some of the procurement issues. But in a country where there is no national health insurance, then the public is vulnerable. So what that means is that the watchdogs for the public in these kinds of settings, like in Uganda, becomes a civil society organizations. And the civil society organizations were disadvantaged when it comes to addressing issues on procurement of public health commodities and essential health medicines for essential medicines, basically, because they lacked training in issues of social accountability and even in the processes on public procurement. So it became necessary through these coalitions, these multi-stakeholder coalitions that we set up in Uganda, to get the civil society organizations trained. And the World Bank did a very good job in identifying, firstly, coming up with a concept paper that identified what the bottlenecks are in public procurement. And then we did a desk review in country of all the systems and all the literature that was available with regard to procurement of pharmaceuticals in the country, and then from there identified what specific issues can this multi-stakeholder coalition identify to rectify some of these issues in the bottlenecks faced with procurement in public health commodities. And some of the very early or quick wins, I would say, is one, we were able to identify empowerment of civil society organizations to be able to do their work well. And one of the things that came out in the very early beginning when the report was shared of the desk review and so forth was that there was a meeting held between the national medical stores and the rest of the public. It was sort of a public forum, but of this of a select group comprising of all the constituents, the multi-stakeholder group. And in this one, there was a dialogue between the national medical stores speaking back to the public, speaking back to the civil society organizations about why are there stockouts, about Ministry of Health. There were also weak institutional arrangements that were identified in Uganda. So Ministry of Health and the public procurement PPDA, the Public Procurement Authority, was able to speak back to the Ministry of Health, about some of the issues that they had tiffs about in a general public forum. And this has been a trust-building exercise. One of the professors earlier, Professor Siri, alluded to the fact that litigation cannot be everything to solve issues on the right to health. And in Uganda, we also saw that there were the civil society groups, like Peter said earlier, were very militant in terms of going to courts to address issues of maternal mortality. There are ongoing cases about mothers who have died at health facilities. And there was no dialogue between the government and the civil society. It was all supposed to be sorted out in the courts, and that was sort of hitting a deadlock. But through this consensus building exercise we have had at the multi-stakeholder coalition, we've had these different constituencies sitting together around the table. A platform has been created, or a space, so to speak, where they can understand each other and begin to use technological evidence, for example, like Professor Siri said in the morning, to generate some of the data that is not available, that cannot be used because it's not there. The civil society organization's capacity has been built to generate that data and then use it with the government. And the government is participating as one that is helping to construct some of the tools for this generation of evidence. So we are seeing a very good interplay between the government and the civil society, and moving away from just the bare litigation, but more towards some sort of consensus building exercise and constructive criticism and so forth. Still on the right to health, there was something mentioned about where a situation where we needed to have so, for example, policy options analysis was conducted in Uganda about 2 years ago, and we needed to know what goes into the minimum health care package. And some of the issues that came up was they needed to go by a Venn classification, vital, essential, and not so essential commodities in the kit system. But that only works for the public procurement system. So we have the CSOs as the watchdogs for the public procurement system, and the right to health issues still come up. Just how much do we put into that kit? And the kit is continuously evolving. And then the civil society organizations have also been able to monitor delivery of this kit at facility level. So they are collecting data, and through the social accountability mechanisms that they have been enlightened, through the capacity building processes, they are collecting data about how well is the kit system faring, how well is NMS progressing, how is NMS working, well, National Medical Stores, working in the local governments, and there's dialogue between National Medical Stores and the civil society. So those are some very quick wins I can say we have achieved, but some of it has also come as a result of the rights revolution, where the civil society organizations have been built in their capacity to know what their rights are as citizens, and then they're imparting that on the rest of the citizenship. So, thank you. Yeah.
Thank you very much, Jackie. Teresa, Can you still hear us?
Yes, we can, Yvonne.
Yes. So Teresa, can you please share with us, briefly describe some of the key stakeholders in your coalition and what are the group interest dynamics and what are some of the major activities of the coalition on the ground and how is this contributing to address some of the PSM challenges that you face in Kenya?
Thank you, Yvonne. Quickly, I'll maybe just share that the multi-stakeholder group in Kenya comprises the civil society, maybe to mention a few, like earlier said, Transparency International as the convener. We have National Taxpayers Association, who are really out to check how the resources of the public are used, or the tax of the public is used. The International Commission on Jurists and the Global Network of People Living with HIV and AIDS, among other civil society members. We also have the academia on board, University of Nairobi, the pharmacy school, and we also have Strathmore University that also is on board. One other key member of the coalition is the government. One thing that we've already heard from the other speakers is that when we started the coalition, it was not easy to get all of us on the table, but we must say that now we have a very good support from the government. The Ministry of Public Health is on board and quite a key player and gives us access to the health facilities where our major activities are. We have KEMSA. Today, at least Dr. Munyo and I can sit next to each other. The first time we were really not looking at each other eye to eye. I remember I was in DC and he was in Kenya and we were speaking about the same country. Then we have Public Procurement Authority, Oversight Authority. We have the Ethics and Anti-Corruption Commission that are also members. Then the private sector, overall, we have the Kenya Private Sector Association as the overall body for the private sector, and also other people on board, the representatives from faith-based organizations and development partners. We've had GIZ, the health sector program, quite supportive. One of the major activities that we are currently running as the FOTAP, that is the Forum of Transparency in Pharmaceutical Procurement, is citizen monitoring, where one of the key things that the coalition thought about is how to engage the citizens to actually speak out and say how they experience the services in the health sector, but more specifically on access to medicine. And we came up with a tool which is very simplified, customized to their understanding. And here I'm talking about level 3 health facilities, that is quite at the community level, but yeah, not so low, but somewhere in the middle at the community level, where the citizens are able to walk to the health facilities and ask a few, they get to be asked a few questions about how they've experienced services in the health facility, emphasizing on access to medicine. So far, pilot projects have been done and major projects now being carried out, supported also by the World Bank through the Civil Society Fund, and this being an initiative that initially had been started by the World Bank Institute. How do we sustain the interest? For sure, working in a multi-stakeholder group, issues are as diverse as the members on the table, and everyone has a particular interest. If you come from the government, you'd want to speak to the policies of the government. If you come maybe from the civil society, you really want to push for what is human rights and the international conventions. The pharmaceutical manufacturers want to speak for something that would push for the agenda in terms of how can they make the best sales and sell their best quality of drugs. So one thing that we had to all remind ourselves is who is our target. And it came to the table that the target is actually the citizen. We all say we are doing it for the citizen. So the question came that then what does the citizen want? And that's how even the citizen monitoring tool came, where the citizens speak out in terms of access of medicine. Then we come back to the table and ask ourselves, then who has the role to do what? To respond to the issues that the citizens have raised. So that if it's about delivery of drugs, KEMSA is able to explain what could really have happened in a situation, if it's a health facility. If it's about maybe quality of drugs, maybe a pharmaceutical manufacturer would talk something about it. And at the end of the day, we sit together and
get a solution that works for all of us. And I think that's what Dr. Munyu started with by saying time has come when we now stop. We are now moving towards stopping to point fingers, but taking responsibility on the table when you have all the key players on the table, especially when you have the government on the table. It's really profitable and beneficial to move, because the facilities are actually moved and governed by the government. Now, how do we really reach consensus and get engaged? The idea is to actually identify what is in it for all the stakeholders in the table. If we improve access to medicine, and I'll use maybe one example. I remember the first time when we started negotiations with the KEMSA, they were really very passionate and concerned about the health facilities being their customers. And the only other thing that we had to share on the table was that, okay, the health facilities can get the drugs, but if the drugs don't reach the citizens, then therein, ultimately, you might not really have the satisfaction you want. And it's at that point that we also entered into a different project where it was the mobile drug tracking system, where KEMSA is able to allow us to use part of their system for where the citizens are able to give feedback. Because if the citizen gives feedback, then you know which health facility probably has not delivered the drugs that you gave, or how the drugs have worked for the people. So once you identify the interest on the table and who it will hurt most, or maybe they would have it as a challenge, then everyone gets to the table and wants to respond to the concerns. I'm not sure if I've left out any of the questions you've asked me, Yvonne.
No, Teresa, you have tried to speak to most of the issues that I raised. But I just want you to quickly talk to what has been one of your greatest challenge. What has worked, what hasn't worked, and why? What would you do differently?
The first and foremost challenge, which Dr. Munyu also started with, is access to information. In the pharmaceutical supply management, the whole chain of the system, there's still a challenge to get information that would be useful in terms of getting solution. And probably it's because we are still all trying to come from the era where information was maybe a secret to an institution, or information was not something that was freely shared, maybe because of competition or one thing. So you find that the citizens who we are all working for in terms of ensuring that there's access to medicine still do not have knowledge on when drugs are available in their facilities, and these are one of the areas that we think of working on. They still are not so sure how much resources are allocated for drugs at the health facility, and how much can they ask for. The other idea recently brought out in a survey that has just recently been completed is that most of the citizens also still do not know information on which drugs are supposed to be given to them free of charge and which ones they are supposed to pay. So generally, in as much as there are various factors that affect access to medicine, including also geographical area, in terms of the citizen understanding the quality of drugs, the main challenge that we have experienced as a multi-stakeholder group is that access to information. Because sometimes even ourselves, when we have a meeting, we have to keep on sometimes calling off to go and see where we can get this information, who has it, and how it can be brought on the table. So what are the advantages or things that we're doing in terms of mitigating the same? The first thing that has worked is that there is a memorandum of understanding of all multi-stakeholder on the table, that if you join, you are free. You are joining and agreeing that you will share information freely that is supportive to the multi-stakeholder group, that you would be able to give information that is useful for the activities of the group. So what has really worked well is that memorandum of understanding, where we even agree to what extent are we working together in terms of achieving the best interests of the citizen that we are working for. And the other thing that has best worked for the coalition is constantly remembering the interests of each party on the table, so that whatever conclusion you come up with, whatever documents you draw, whatever activity you plan to do, you have the interests of all the multi-stakeholder group or the members at heart.
Thank you, Teresa. Let's move to Tanzania to find out what is happening in the multi-stakeholder coalition. Joseph, what are some of the key activities you're undertaking, and how do those activities contribute to addressing some of the PSM issues?
Well, the situation in Tanzania is not very different from that has been described for Kenya and Uganda. Remember, these are three countries which have been which have all been under the British system for many years, and they have similar laws, similar outlooks, and similar culture as well. But the first thing that we observed when we started this multi-stakeholder approach was the absence of civil society on the ground in Tanzania. There were no active civil societies at all monitoring either procurement or, to be more specific, pharmaceutical procurement. So all the voice that we hear of the people's voice that is contributed by the CSO in the various activities in Uganda and Kenya simply do not apply in Tanzania. That was the first challenge that we had. And we said, now where do we start? And obviously the first place to start was to build a CSO base. We had to start all over again, identify prospective civil society organizations that were there working in the health sector in one way or the other. Most of them have got multiple directions, education, health, and the like. So you just try to identify one which would have an inclination towards health and especially towards pharmaceutical, bring them up, groom them up, and then, try to show them what role they can play. This has been a very big challenge to us, but we believe that now we are in a stage where we can start looking forward. Now, about a year ago, we undertook a pilot a study that would look into PSM activities in the rural areas, in the provision of medicines in rural areas in Tanzania. We did that in one region, in Dodoma, which has 6 districts. And due to the lack of the civil society on the ground, you could see that the main players in the pharmaceutical provision arena were the Pharmaceutical Distribution or Supply Organization, the Medical Stores Department. You had the PPRA, which is the Public Procurement Regulatory Authority, which looks at how the procurement is done. But the general impression that the PPRA had at the beginning was that there is no pharmaceutical procurement that is done at district level. Rather, the district are required to buy their provisions from the MSD, and the MSD is the one which does the central procurement for the whole country. But we found that the situation was rather different. The picture was changing, that there was a significant procurement that is done at district level, and therefore there was a need for some kind of civil society intervention and citizen monitoring activity at that level. So what we did was we brought together procurement officers and pharmaceutical officers and civil societies in district offices in the district, and told them to go out and do contract monitoring and stock monitoring exercise, at least up to the level of the district. They shouldn't go very far to the rural health facilities, because that would have been a very extensive activity. We sent them off, but before sending them off, we brought them together in a workshop. And in so doing, we realized that we've done something that was incredible. And that is in the spirit of the multi-stakeholder group. We found that the teams came up and identified to each other. They looked at the task as a common task and not as an individual task. The procurement officer depended on the pharmaceutical officer to show him exactly what the plans were and the projections were and the like. And the pharmaceutical officer looked at the procurement officer to look at the procedures that have been taking place with regard to the procurement, particularly when it comes to systems of procurement, whether it is from the medical stores or from the private sector and the like. And the civil society was there learning, monitoring, and reporting back. And at the end of the day, that collaboration really reflected the spirit of the multi-stakeholder approach. It really helped raise the position of our organization in the spectrum, or in the national spectrum, to the extent that when we asked the chairperson of the parliamentary Committee on social activities to launch the multi-stakeholder group, we didn't have any objection, and they actually invited us, if possible, in future to incorporate them or to report them back to them so that they could use the information, the hard data that we collected on the ground in the parliament to be able to to facilitate decision making. So this is one thing that we have managed to achieve in the country. And at the same time, we've had some takeaways for the coalition members. Coalition members like the PPRA, coalition members like the Medical Stores Department, the Ministry of Health, all had bits and pieces to take away. PPRA is the one which provided the initial tool that we modified to do the contract monitoring activity. So from that, they managed to get a lot of information on how procurement is performed at ground level and what sort of improvement needs to be made. The Ministry of Health came up with a tool that we used for stock monitoring. And they also learned a lot on the availability of these medicines. And as a matter of fact, as I said initially, they were oblivious of the fact that there is quite a significant proportion of procurement that is done at district level in the private sector. When you look at the big picture in general, without the medical stores, without the private sector procurement in that region, stock out level could have reached the level of 30% to 40%. While what the real case that we discovered while doing the monitoring, the level was about 20% to 15%. So you can see that at the end of the day, the Ministry of Health learned that there was a significant role that the private sector is playing, and therefore we need to look at the possibility of bringing in the private sector into the coalition as well, because definitely they will have a very important role to play. Maybe I should stop there in case there's another question.
Thank you very much, Joseph. I work closely with these coalitions, and therefore I have some insights. And I know that one of the greatest challenges they play is bringing the private sector into the coalition and sustaining their interest in the work of the coalition. We are lucky today to have Jackie, who used to be the coordinator for META and has since transitioned to MEC as a private sector person. Jackie, would like your insights on strategies for effectively engaging the private sector in the coalition. How can we attract the private sector into the coalition, and how can we sustain their interest?
I have only 3 minutes to answer that question, and I'll be brief. My only answer is in one thing, and that is content. I mean, the conversation at the table needs to be relevant to the private sector, because as you know, now I work for Merck, which is different than working for Meta, and time is precious. It has always been precious, but it seems more precious in certain circles than in others. So you sort of want to go to a meeting where they're just discussing the issues that are relevant to you and not sort of beating about the bush and just having a tea party or something like that. So I think it's one of the things that we need shaping with the coalition. If the private sector, and in this case meaning multinationals, because in Uganda we do have the private for-profit, local manufacturers, and then we have the private not-for-profit, faith-based organizations, but now there's the multinationals who are coming into the coalition. But just to say that for this other group of people, I think it's very important that we are discussing issues that are relevant to our business per se. So it's important that we are discussing issues on how can the government become a better business partner in this coalition? How can the government deal with the issues of delays in contract monitoring, issues on underfunding for procurements and so on? So it's sort of just getting the government to become a better business partner. That's how I would look at it. So I'm sure through the diffusion process at the coalition that can happen, but we need the content. We need our issues stable in this coalition. So that goes back to our work plan. Thank you.
So we have a couple of minutes to go, and we've had some very useful and informative pieces from our panelists here. But I just want to do a last quick round with all the panelists where you have exactly 2 minutes to answer this last question, and then we'll open it up for Q&A so that we can also hear from our audience. We've heard a lot about how to engage, how to form coalitions, how to sustain their interests, and how to work together. We've also heard some of the challenges and also the benefits of having such a coalition in place. But the question still remains, how do we ensure the long-term sustainability of the coalitions? How do we institutionalize them so that as the bank moves away from providing the support, the capacity support, from facilitating the process, they can really integrate into the way business is done at the policy level, at the regional level, and also at the periphery where services are delivered? How do we ensure that we are building coalitions that can survive, that can be sustainable, and that can be institutionalized into the policy-making process? Let's start with Peter.
Okay, thanks, Yvonne. I think the issue here really is on the form you want the coalitions to take, and in which case then what you want to sustain, or whether you want to move away from really sustaining institutions to working more with activities. And I think that will need to be discussed and agreed by the respective countries. Two, there needs to be a consensus on the agenda, given the fact that these coalitions bring in different stakeholders, right from the private sector. And when we talk about the private sector, we are not talking about a homogeneous group. We're also talking about a heterogeneous group. So the question, I think, will be, who are the people who are relevant for the agenda that the country wants to take and to promote within the stakeholder grouping, with whatever form and whatever name they want to give it. Two, in all these countries, what I do know is there have been increasing numbers of, whether they are called technical working groups, whether they are whatever name, they are actually involved in tackling issues of medicines. Others are more specific and they include public sector management. Others are broader, they look at not only medicines but other aspects of health. And I think, to me, we should start thinking of how to integrate these activities in these existing structures, which already bring in both parties from government, but as well as the private sector and academia. Lastly, the key, I think, what would be most important and I think continues to be seen as relevant is the issue of managing information flow and ensuring that vital information, particularly in these areas that we think are critical, we get ways of making sure that this information really comes to the public. And this is where the media particularly are critical. So one of my recommendations would be that we need to start slowly by bringing in the media, because in all the three, the media currently, while I know we have sessions with the media actually still does misinform the public when it comes to medicines. And they are becoming a very big force given the liberalization of the media in the countries, both radio and newspapers. So that is my second last. And lastly, I think the relevance then of the bank, of government and other institutions would be, how do we support NGOs in those areas? And my last comment, and as I support Tanzania, is I think we still do have challenges in sustaining interest of civil society in this area. And this is largely because of funding. most of the funding available to civil society when it comes to health is largely directed towards service delivery. There's very little money available for advocacy work. So when we see many of these NGOs currently doing this work, many of them really do it out of their interest, their commitment. But largely, you'll still be shocked that the funding which they got really came out of a budget which was directed not towards advocacy, but to something else. So the question is, can we encourage governments, can we encourage development partners to really start critically looking at the importance of advocacy for health, and while they still continue supporting particularly service delivery, whether it's HIV, whether it's malaria. I think they are both critical, but I think bringing all this together would give us greater impact. So those would be my comments, Yvonne. Thank you.
Thank you. Jackie?
Okay, my comment on this one is going to just arise out of my former role, which is that I was a secretariat coordinator at META. And at the time when META ran out of funding is when we sort of saw it crumbling, and then WBI came in to help in good time. So basically what I'll sort of allude to is the fact that as we discussed the future of META in the London summit that we had, the Global Forum in 2010 in July, the government of Uganda came very strongly to say they wanted to support META going forward, and they actually put forward suggestions about funding that they could give for as long as META wanted it. But when we sat together as an in-country group, we decided as a coalition that we did not want the funding from government of Uganda, because as a matter of fact that would make us answerable to them. So how do we ask them to be transparent and accountable when we are dealing with the issues that they are grappling with? So then I went through a process as the coordinator, trying to look around for funding, and I approached the different groups in country on health. But one of the most insightful discussions I had was with one particular group, which basically said, we need government of Uganda support to move META forward, but we do not need financing from government of Uganda. So we need to look out other than the government's support. How else can we get financing? So my conclusion on this matter is we need to diversify the resource base for these kinds of coalitions. Beyond just one donor, can we think through mechanisms where we can have some sort of diversification so that the coalitions are independent of influences, undue influences from any one party, but can have some sort of international acclaim, and we can publish a lot of our work, because this is a very new area for many respects. So I'll just call upon the group here to think through institutionalizing funding. I don't know, however, the mechanisms might be, but that might be something that to think through the coordination aspect of the work for the coalition. Thank you.
Can we hear from our colleagues in Kenya? And while we're in Kenya, I would like to acknowledge the presence of Kimbura, who is part of Dr. Munyu's team. Dr. Munyu, can we have your comments on the last question, and to be followed by that of Teresa?
Yvonne, I guess the last question we are looking at the quick wins, if I'm getting you right.
We are looking at how do we sustain the coalitions, and how do we institutionalize them?
Yes, that's precisely what I'm talking about in a different language. And the way from where I sit, the way Yvonne will sustain the coalition, and I'm talking specifically about our coalition FOTAM, is really looking at the low-hanging fruits that we need to harvest to make it strong and to keep it going. And first and foremost, from our perspective in Kenya, I'm looking at the Citizens Drug Tracking Tool or tracking system, which we are glad to the World Bank Institute, which you funded and we have piloted, and it is fully working, which, as Teresa said, it is anchored at the Transparency International and hooked into the KEMSA Enterprise Resource Planning System, and the two systems are talking to each other. I really think to sustain the work of coalition in this part of East Africa, we need to roll out this system. We need to train all the members, the stakeholders, the civil society, and we need to have this system, this citizens tool, covering the entire country, and it's going to create interest. We have seen the response and the kind of results that we got from the pilot that we did. And therefore, if we roll it out, it's going not only to generate interest, but even those members, like the ones from the private society, who my colleague claimed that they have limited time, they will find that there is more benefit. The opportunity cost and the opportunity benefit that comes with it is much far bigger than the time that you spend in it, because the benefit will spill over to all the stakeholders in the industry. And the other important thing that will keep us together is if there is information flowing. We started by saying access and flow of information is a problem. And for us in Fortam, we are lucky because KEMSA's systems are fully automated. We have a portal where all the citizens can hook into a portal and get the information. And we are looking to going to the next stage so that we can create the interest and everybody can see the benefit of being together, where they can be able to hook into this portal and get access to this information so that we are properly informed, and information is power, and when the civil society and everybody has the power, what we'll eventually be doing, my colleagues, is that we'll be creating an M&E group from the civil society and everybody, with mechanisms and structures to be able to monitor what is happening in every corner of this republic. And that is the information that we so badly need to be able to monitor what is happening, so that corrective action and strengthening can be done where it's appropriate. I really think that these are the things, in addition to what my colleague on the other side has said about advocacy and training. These are the things that we really need to do to keep the coalition going. We need to do training. Training is important because there is a lot of lack of understanding and lack of appreciation. What are the benefits of bringing all these multi-stakeholders together? And I remember when KEMSA joined this group, my seniors in the Ministry of Health asked me, are you sure you are sitting around the table, you are going to bed with the right people? Are you sure these noisemakers are not looking for faults and this and that? But 1 year, 2 years down the line, we can see the benefits. And let's look at this, the gaps that we have. As I have said, I'm talking from the Kenyan perspective. If we address these gaps, we roll out the tool, we address the issue of access and flow, and we already have the basic systems in place, and we have the M&E mechanisms in place for all the citizens, all the players within the coalition. I'm sure we'll be far away in achieving the objective that will improve PSM in this part of the world and strengthen the systems, and the beneficiaries will be the citizens of this part of the world.
Thank you,
So
Dr.
Yvonne, as you walked, I was just saying, as you walk to the podium, I could finish on my part. I think one of the greatest opportunities that we also have is taking advantage of the new systems that are coming up in Kenya. So it's very nice to hear that finally KEMSA has gotten the new law to become an independent authority, where now we'll really be able to hold them accountable, because now they have all the resources with them and be able to even engage with them further. In fact, I was telling Dr. Munyu, as we celebrate about that law, it just means more responsibility for KEMSA. So we take advantage of such kind of opportunities to work with them, because they're already our friends on the table, so most of our ideas can pass through. And then Kenya is also coming to a time when we are going to implement the decentralized system, where resources go to the people at community level. So probably it's also time to increase our efforts towards monitoring how these resources are being used, especially towards access to medicine. And as I finalize, is that we should all not forget who our target is and who our beneficiary are, who brings us on the table. Citizens must just access the medicines, and monitoring shouldn't really be looked at as fault finding, but monitoring should be about also improving the systems and seeing where we can put our synergies together to make it work. Thank you.
Joseph, you have the last word.
Yes, my prescription to the problem of sustainability would have 3 items. The first item is to make sure that we have tangible outputs. By tangible outputs, I mean that we must have noticeable results. because these noticeable results are the ones that are going to ensure that we are going to get more activities. I'll give an example of what has happened in Tanzania out of the first activity that we did, which was still at the pilot level, and the Ministry of Health has seen that, and they are looking at the possibility of using the coalition to do citizen monitoring on behalf of the Ministry of Health to monitor all aspects of health delivery at rural health facilities, including pharmaceutical supply, which will be very important to us because we'll be able to link or to bridge the supply side to the demand side of the PSM. So if you have tangible outputs, I believe that you will have more, you might call them customers, and therefore you'll continue to have more activities to do to ensure the sustainability of your of the organization. Then we must also expect to have fluidity in active membership. We should not expect that our members will always and continuously be actively engaged at all the time. There are sometimes that some of us will go to sleep because the activities that are being conducted at the particular time will not be very relevant to us. We must be ready for that, and we must not complain. The MSD will not be very much interested when you are talking of procurement issues, particularly when it comes to regulatory issues of procurement. For the time being, we know we have the Tanzania Food and Drug Agency is a member of the coalition, but it's not very active because we are not yet looking at quality issues and the like. The time will come when we engage into those activities, and they will also buy in and they will become very active. So we should expect fluidity in active membership at any particular time. Finally, and the third item on the prescription is real-time political or technical relevance. Our activities must be relevant. At that particular time, we must keep our eyes skinned to see exactly what is pertinent and what is required in the community at that particular time. And in so doing, I believe funds will come in. Thank you very much.
Thank you. Thank you very much. Shall we give our panelists a round of applause? We'll now open it up for questions and answers. Okay. We go with you first, Norma, and then... you have to come up here. Sorry, unfortunately. We are webcasting this on an online platform.
Thank you. My name is Benjamin Herzberg. I work in WBI in the issue of private sector engagement for government programs and stakeholder engagements. One, I would like to make a call to the greater community of practitioners. I think it's time to get a bit more precise on the mechanics of coalitions, because you all mentioned a number of things in different coalitions you have supported in Uganda, Tanzania, or Kenya. In terms of typologies, what kind of funding and when and by who, what kind of anchorage, who is hosting it, who is facilitating it, how is it structured, what kind of recommendations are people doing, and all those things. I think it will be important to really create frameworks around this. And so I think there's some knowledge work that needs to be done to categorize how is it so that we can actually scale it up later on. Second, in terms of the private sector engagements, the three partnerships, I've been looking at it very narrowly, I find, on the issue of procurement. But you got, I guess, to consider the entire ecosystem as to who are the pharmacists, who are the nurses, how are people trained, what kind of infrastructure, what kind of financing you have for people to do technology upgrading, what kind of innovation solution, what kind of regulations you have as well, and what's the role of the private sector in there? Have you tried to do a broader engagement with the private sector on the health system as a whole, as opposed to looking at the particular issue of procurement or procurement for medicine? Because I think it's very difficult for the private sector to engage. I mean, it's good to be focused, but you also need to consider the big picture, which might make it more relevant for people like Merck, for instance, to use their convening power to actually engage in dialogue with the government. Thirdly, in terms of the government, it looks like we have a bunch of NGOs, it's great, we can fund those and prop them up. But what's happening from the political will? Is there a strong anchorage at the government level? And do you have this strong political will? And finally, in terms of integration to World Bank operation, how does that work? This work so far, the three coalition, has it been done kind of on the side of World Bank operation, or was it financed by World Bank operation, or is it complementary, or how does it work? Thank you very much.
Hi, my name is Norma Garza. I also work for the World Bank Institute at the Open Government Practice. And hi, Teresa. Nice to see you.
Hi, Norma.
My question is mostly around, the communication channels. We talked about a lot around the information flow. So I'm just curious if any of the speakers can share any lessons learned or a best practice around communication channels between the different stakeholders that are part of the coalition, and actually how this has facilitated the information flows and particularly translated into closing the feedback loop between the government and the beneficiaries.
Lord Sansom, I wonder if I could ask the three countries whether or not these coalitions were established under a framework which had high-level principles with which no partner could disagree.
Can you repeat that? Sorry, I didn't get it.
Well, you set up the coalition, but was it in a framework which operated under a set of principles or aspirational goals which actually held people accountable for their actions within that framework? Okay? So in other words, it would be equity of access. There are a set of principles with which none of the stakeholders could disagree with, and it's in that spirit of which they come together. And I'm just wondering whether you actually established the framework first and then the coalition, or now you're trying to find a framework that will sustain the coalitions.
Can we respond to there are about 5 questions on the table, and then we'll take another round of questions. So can we start with Peter on integration of the coalition work into bank projects? How is it funded, and what are the opportunities for the bank to support the work of the coalition?
I think this is where you have a problem. Many of these coalitions are fluid coalitions. And given the discussions, I think you had with Jackie, it's quite clear that the coalition in Uganda did not feel comfortable accessing funding from government. Yet, on the other hand, for the bank, our client is government. So it is obviously an issue. I do believe, though, it is possible that maybe some of these activities, if it is so agreed, that they could be financed partly through the credit. But the idea of sustaining the coalition itself, meeting the Secretariat's costs, those I think would be problematic from both sides. For the coalitions themselves, they obviously have fear that they will lose the independence, and so that is a challenge.
Can I just elaborate a bit more, because I know what goes on in the coalitions, and I think there are options. I mean, what do we mean by funding? Can we have joint programs under the projects, or should the projects be funding the coalition? In Tanzania, we're currently working with the health sector project to roll out a social accountability program for the project in Tanzania. And we're working closely with the ministry to design the tools, to build the capacity, and also to implement, pilot, and roll out the community scorecard process. So that, in my opinion, is how we're able to integrate and leverage resources from projects, which is quite different from getting governments to actually fund the coalitions. And to allude to what Jackie said, it becomes very difficult to hold the same people who are funding you accountable for some of the mistakes and some of the inefficiencies in government. So it's very critical that we balance it. How do we build coalitions that are robust, coalitions that engage, coalitions that are able to show results, and how do we make them attractive so that they become partners in the whole discussion in the health sector? There was a question about broadening the scope of the coalition to make it more attractive to the private sector. While we agree that this has to be done, this is a new approach. We're trying to start small. We're looking at a very small specific issue in the health sector. How do we work with different partners to put the spotlight on procurement to make it more transparent so that there's better accountability and efficiency in that process, with the hope that as we build the capacity, as we build the relationships, as we build trust among the different stakeholders, we can actually expand the scope to look at other issues in the health sector. So while it may look like we're focusing on a very small part of the health system, it's part of an approach to make sure that we become better at this, we learn our lessons, and we are able to scale up in a more efficient way. Teresa, do you want to take the question on the communication channels and the feedback loop?
Yes, Yvonne, I could quickly take that. We can see on our screen we are being given a 5 minutes warning. I don't know if that's the same on your part. But I'll quickly try and say that the communication channels, to get it clear, first you must agree who the person sitting on the table must be someone who can also make decisions and also communicate the information of an institution. When we talk about access to information or freedom of information, it has a limit of what can be said at what time and what would not cause anxiety around the country or even the stakeholders on the table. So how we've done it to get even information flow is that we try and identify senior or key people in various institutions who then can share the information or even communicate to the group in terms of information that needs action. Just quickly to respond to the issues of funding of stakeholders, I think you said it very well that we still remain as watchdogs. That is the civil society in that sense. And most of the time you find that civil societies, out of their interest, most of the people sitting in this table have programs that are already running in the organizations. So they bring the resources that they have. So ultimately, all resources being distributed by development partners to different organizations in one way or another meet in the middle at the table when we are doing joint activities. And the government's resources necessarily might not come in as cash, but resources in terms of opening doors towards the facilities that we are supposed to work with the facility health workers to monitor, and also provide resources in terms of even the information that we need to make sure that the citizens effectively participate.
Okay. There was a question on aspirational goals and the framework for accountability. Jackie, do you want to respond so that Joseph can also contribute? Which is the last question we had before we take the next round of questions.
I'll begin by giving a brief history of the coalition and how it started in Uganda, which was basically that the British government, which was DFID, really wrote to the Ministry of Health of Uganda asking whether Uganda would be a country that is interested in working with a multi-stakeholder coalition whose principles really was transparency and accountability. And it was basically to see if Uganda was interested in working on information disclosure. So Uganda agreed, wrote back to DFID, basically agreeing to those principles that they would work on transparency and accountability with regard to information disclosure, leading to improved access to medicines. So that was really the genesis of this coalition. And even now working with the World Bank Institute just followed from the Meta principles, which was really underlined by transparency and accountability. But also to let you know that Meta was seen in the beginning, and I think still is, as a mechanism where countries could be pre-qualified to receive donor funding. So basically it was that if countries had a Meta process ongoing successfully, then that should open doors to donor funding, because then they would know their mechanisms and processes to ensure transparency and accountability of the funding going into the pharmaceutical arena. Yeah, that's what I would say.
I've just been told that we're running out of time, so can we take the last set of questions and then wrap up? Yeah, and then we'll take questions. I will take questions from ENEP.
Yes, Claudio Santibáñez from WBI Capacity Development. In the previous session, we talked about the right to health, and it was really about how you can obtain social arrangements that provide meaning to operationalize a right to health, and social arrangement that would say will be sustainable, universal, and with legitimate. My question is, does a multi-stakeholder coalition aspire to get social arrangement in your particular and specific exercises? It's about getting social arrangements in the sense to be decisions that are legitimate at a social level, and if that is the case, and if not, if it's about getting some solution to a particular problem, please also if you can extend on that. But if the case about getting social arrangements, where have you feel in your own experience that social arrangement has been produced? In a particular process, in the gain of trust from the multi-stakeholder coalition, in a particular bill that was passed, or in any other establishment or any other activity. So my question is, as well, if it's going to a social arrangement, which in your particular case as well and experience are those stakeholders that are still missing from this coalition? And if there's no missing stakeholder, please tell us as well. Thank you.
Okay, we have a couple of questions from our community of practice online, but in the interest of time, I'll ask only one. This one is from Celestino Kucheno, who's from Zambia. He says, I have noticed that Zimbabwe sometimes faces challenges in the ARV supply chain when their suppliers, who are WHO pre-qualified, have quality issues and cannot deliver on the agreed dates. How do other countries of similar resource-limited settings overcome such challenges? And will the multi-stakeholder coalitions be a good platform for doing this?
My name is Patrick Osewe. I work in South Africa for the World Bank. For many years before I became a World Bank bureaucrat, I was a medical doctor and a research scientist. And in medicine, medicine is a very technical subject, and medications are even more technical than the field of medicine. I don't recall any time that a patient came to me and wrote a prescription and started challenging the prescription that I did until HIV became a problem. Because with HIV, particularly working in a clinic in Atlanta, those who were affected were very much on top of their condition. They read the latest journals. Sometimes they were more informed than me, the medical doctor. And then they had a very, very powerful coalition that put pressure on government to provide funding to enable treatment to be made available and to finance research. And so that coalition achieved a specific objective. And I think that we are talking about a coalition here, and I think that the coalition, a coalition in this field is very important, because I feel that people are very much misinformed. People don't know about their rights. People don't know what is expected of them. And in an African context, many people, when they go for healthcare and then they do not get medicines, it's almost expected. If you don't get medicine, that's fine. You're going to buy it anyway. And so by having a coalition together to start educating people, for me, the way that this coalition can sustain itself is to be able to share information with the public, to be able to educate the media, because the media is so much misinformed. I mean, if the media is misinformed, then you don't have an ally. How does the media become part of the coalition, or how do you develop a system in place to be able to educate the media so the media is on your side, people see the relevance of the coalition, and the agenda is very clear? And when we are thinking of the private sector, it's not just the pharmaceutical companies. There's a whole private sector players that should be included, like the logistics supply management, like Coca-Cola. Coca-Cola, you find Coca-Cola in every corner of the remotest part of East Africa. How are they able to do it? And we cannot do medicine. And there are only 5,000, for example, in Kenya, there are only 5,300 health centers in the country. But there are thousands and thousands of outlets that are selling Coca-Cola in all over East Africa. So how do we make the coalition relevant? By providing more information to the public, because at the end of the day, if the public is informed, they'll put pressure and it'll make the coalition relevant, and you can get funding from government, either from government or from any development partner.
Thank you very much. Joseph, do you want to take the question from INEP?
Okay. Obviously, this could be a country-specific problem, but yes, it does occur in many countries. In the case of Tanzania, for example, we do depend very much to fill the gap using local manufacturers. We do have a couple of companies with capabilities, not WHO pre-qualified, but with capability to be able to produce those medicines and supply and fill in the gaps when there are shortages. That is what has been happening so far. We've had problems. Recently, we had some substandard products that were reported. We need also to have in place mechanisms that would respond very quickly in case there are any problems with regard to quality or something of that sort. But apart from that, I can't see any other option apart from good PSM management.
Okay, we have run out of time, and it's been a very useful discussion, and there's been a lot of issues put on the table. Relevance of consensus building, providing systems and mechanisms to disclose information, the critical need to get feedback from citizens, and demystifying PSM as a whole. How do we stay relevant? How do we generate tangible and useful outputs that are relevant to the stakeholders that we work with, and also contribute towards the broader agenda of improving access to medicine? And we can go on and talk about many of the challenges and yet the opportunities that we have. For me, I think that has been a useful exercise. We're beginning to learn some early lessons on how to build coalitions, how to sustain engagement, and also how to stay relevant. On that note, I'd like to thank our speakers again and to hand over to Maria Luisa to wrap up for the morning session. You can all go to the side.
Thank you, Yvonne. Well, I just want to say that it has been a privilege to have all our visitors here, including our colleagues from Kenya online, and also those that are on Salud Derecho and on INEP that have been sharing with us this discussion. So for me, as a take-home message, is that I see that there is so much work around trying to support countries and societies to really achieve universal health coverage. And these two sessions have shown us what are the challenges of really operationalizing the right to health for everybody and going towards universal health coverage. So I think that transparency, accountability, and participation and empowerment of citizens so they can participate seem to me four topics that were underlying in both of the sessions. So I invite you to also ask all the other questions you want to ask during the lunchtime to our visitors that are around here. And many thanks for all of you to be here. You can go to the Preston. Thank you.